So many physicians are leaving the field right now. They're very unhappy.
They know they're practicing sick care. It's not health care, it's sick care.
The paleo diet was the key for me. How do I feed a 34-year-old healthy man in order to keep them healthy?
They don't teach you that in medical school.
Let's build a system around the permanence of health, not the periodic treatment of disease.
A lot of times people just say, oh, well, it's just my genetics, but there's an epigenetic factor that has a lot more to do with things than the genetics.
What do you think is more important, nature or nurture? Nature being your genetics, nurture being the environment you grow up in. The system is really not geared for health, it's geared for sickness. One female client lost over 150 pounds by just following a paleo diet. Her ability to get through her day, it's all changed.
Testosterone rates are dropping.
Plastics are permanent endocrine disruptors. Once a polystyrene plastic molecule has bound to a testosterone receptor, it is permanently bound.
That's scary.
It's totally scary.
Dr. Howard, welcome to the podcast.
Good to be here. Thank you for having me.
Yeah, so you're a surgeon by trade. You're a doctor in Nashville, and I don't have another doctor in Nashville. And so people always ask me, oh, where do you go? And of course, I get my blood work and stuff at my hospital and stuff. But if I have anything in Nashville, you are who I text or call. And I completely trust you with that. So I appreciate you being there for me on that one.
Absolutely. I appreciate it. And thank you for the confidence and, in what we do.
Yeah, absolutely. So where did you get started with your medical school, with your training, those type of things?
I grew up here in Tennessee. And after, getting my first couple years in college done, I originally started out, I wanted to do physical therapy. And then I thought, well, probably a better role for me as being a physician. I had, in high school, I'd worked in a local pharmacy that was owned by a cousin of mine and did home IV therapy. I learned how to do some compounding of drugs in that environment. This was the early 90s at that point. So I had a pretty good hands-on experience coming into college. And I thought that, medicine or healthcare was definitely in my future. And after I went to a community college the first year, we really didn't grow up with a lot of money. So I got like a needs-based scholarship to go to a community college for the first year. And then I ended up going to the University of Tennessee at Martin. I graduated there. And then I came out and I realized that as a student in that time with my scores in GPA, which were a little above average, but basically average, that I probably was not going to get into a U.S. med school. So I started to look at alternative options for that. And I ended up going to St. George's University, which in my opinion was the premier Caribbean medical school, especially when it came to leading you to a residency in the U.S., at least a good quality residency program, and then having a very high first-time pass rate on the USMLE Step 1, which is kind of a critical test that you got to take. It really sort of determines the quality of your residency that you're going to get. So I went to St. George's, spent 2 years in the Caribbean islands, which was a great experience. Did Step 1, did well on Step 1, which was crucial for me. As a foreign medical graduate at that point, I knew I wanted to do surgery. I knew I wanted to do surgery kind of at the end of my first year of medical school. I felt like that was probably where my heart was leading me to. And once we got into clinicals, my first rotation was surgery in Brooklyn, New York at Lutheran Medical Center. I haven't been there in a long time, so I don't know what it's like now, but in those days it was a great place to learn. And I got a great education and then ended up meeting my wife, and not in Brooklyn, but in New Jersey. I continued my rotations over in New Jersey, did my residency at Lehigh Valley Hospital in Pennsylvania, did a general surgery residency there. At the time, it was the busiest level 1 trauma center in Pennsylvania. We had burn unit. The hospital doubled while the time I was there. I mean, it was an excellent training program. The men that trained me and the women that trained me were really high quality individuals first, and then second, exceptional clinicians, exceptional doctors. So I got a great training, came out, decided I'd actually signed up to do a fellowship. I wanted to do plastics was what I wanted to do. And for various reasons, I wasn't able to make that work. And I was asked at one point if I wanted to go and try to do a pediatric heart surgery fellowship, or, general heart surgery, general cardiac, and then specialize in pediatrics. And I love kids. I always did well with them and was able to work with them very well. But anyway, that I just didn't feel like that was my calling. So I did sign up initially for a burn trauma critical care fellowship at Lehigh Valley. And then after considering all the factors, I said, no, this is probably not the right path for me. So I came back to Tennessee, started working as a hospital employed general surgeon, which was a miserable experience to kind of phrase it.
What year was this?
It was 2010. I graduated residency.
Okay.
Yeah. And so I finished residency, came back, started operating in a local hospital, and the people were great, right? The ability that I had to take care of people that I grew up with, right, that I knew was really, it was fantastic. The problem is that the quality of care that we were able to provide wasn't quite, where I thought I could really do my best.
Yeah.
And so I also had simultaneously started to experience some health problems that I believe were the culmination of residency and the stress that residency sort of put on my body, but then also making some bad choices at a time when my body was trying to recover from residency. What I mean by that is 3 months after I started working at this hospital, I'm gaining weight and I'm looking around the room at the doctor's lounge going, you're starting to look like that guy and that guy over there. You know what I mean? This ain't looking good.
Yeah.
And the common denominator is that you guys all meet for lunch in the same place and you're all eating the same crappy food.
Yeah, buddy.
So I started to change my diet, right? This was like early 2011. I went really deep on learning about paleo dietary philosophy, reading some of the old papers and sort of old thoughts that had been generated around that. Mm-hmm. And I felt like Lauren Cordain has some great work out there if anybody ever wants to read that. But I felt like the paleo diet was the key for me, right? It's sort of, and I remember giving lectures to medical students on surgical nutrition. And, if you had short gut syndrome or you'd lost your large intestine to some kind of disease process or whatever, I knew how to feed you. But what I didn't know was how do I feed a 34-year-old healthy man in order to keep them healthy? It's a different strategy. And
they don't teach you that in medical school.
They do not teach you that in medical school. I'm sure you're not surprised by that, right? No, neither should anyone else be. And that's, that's another thing I'm sure we'll have a chance to talk about, but the system is really not geared for health. It's geared for sickness. And so I started to realize that very quickly. I put the paleo dietary philosophy in place with my clients or my patients who I was treating at the time. As a general surgeon, I did a lot of colonoscopies and a lot of upper endoscopies. I think I've done over 10,000 colonoscopies and about 5,000 EGDs or upper endoscopies. And you start to realize patterns. You start to realize how you can help people. I had got to a point where I was able to advise people about how to do things without the need of surgery and medicine. Mm-hmm. And I thought to myself, like, okay, if you want this, if other people want this, then let's build a system around the permanence of health, not the sort of periodic treatment of disease. And so in 2017, we launched Compass, kind of really built off of my experience and not only kind of helping myself, but then kind of moving forward with other people and helping them achieve the same goal, of trying to get healthy.
You've spoken of healthcare's failures to prioritize actual wellness. What specific changes, would you implement within the system?
It's interesting, so this whole Make America Healthy Again movement has caught a lot of traction. And I think there's actually, thankfully, a lot more awareness now about what all of the facets that I think could be changed to fix that. Mm-hmm. And I did kind of set out an agenda, if you will, about if I were to be asked to participate in the Make America Healthy Again movement in some way with my experience, what would I bring to the table? What would I recommend, or how would I try to attack this problem? And I think that there's definitely subcategories that you kind of got to break down. I think everything from insurance and regulation needs to be evaluated. I think that we need to train doctors differently because the training, unfortunately, is actually, most people don't know this, but postgraduate training or residency training in the U.S. is actually funded by the Medicare system. So Medicare basically pays the hospitals a stipend for each doctor that they train. And so the hospitals do make money off of having residents there. Mm-hmm. And that system is funded by the federal government. And so I think that training has to be evaluated. We need a revamp of what's allowed in marketing. I sat on the couch the other night and I was watching some Wegovy or some other, I don't know what it was, but it was some drug on commercial on TV. And I told my son, it's like, we're like only one of 2 countries in the entire world that allow this to happen, multiple antidepressants seen over the course of a 1-hour TV show kind of thing, And I think, so there needs to be truth in advertising along with marketing, meaning that people need to have labels that accurately reflect what's going on rather than food trickery. I mean, it goes deep into that. I think that we really have to evaluate all facets of this, even like access to certain types of therapies. Why is it that we can't have BPC 157,
hmm
but we can have cisplatin, as a chemotherapeutic option? And yet, BPC 157 really, in my experience and what I know, I can't find a single reported case of harm.
Yeah.
And so there's a lot of things where when
You
these
can't
drugs
patent
are,
it.
I'm sorry.
It's because you can't patent it.
That's right. You can't patent it. It's not really a profitable venture for these companies,
Yeah.
and it's definitely going to take away business from them.
Yeah.
Because if I'm squirting a knee with PRP and BPC, you're not going to need a surgery, and so it's going to steal money from the system overall.
Yeah.
If I squirt a knee with those types of peptides or compounds, we're pretty much going to be able to, at least most of the time, avoid a surgery. And so I think that the incentives need to be changed. And I think the insurance market would actually be a good way to kind of attack a lot of this, because you should. Ideally, we should incentivize people to save pre-tax dollars to use for their basic health care, right? In other words, most people are going to end up in their doctor's, primary care doctor's office, let's just say a couple times a year, once for a physical and once for a sickness. So what if we were allowed, we knew the cost of that. We knew that we could incentivize people to take pre-tax dollars, put that in an HSA. Then when they need that money, their insurance is not involved in that transaction. Their insurance would be involved maybe if they needed a surgery and I tell my clients this on the kind of primary care side of things, whereas a lot of people access us or utilize us as a primary care sort of arrangement. And while for a lot of people, they will pay out of pocket for that and still keep maybe even an insurance-based primary care doctor in case they need it, what they also realize is that we're using our dollars in a much more efficient way. And I tell them, don't go to your primary care doctor or use your insurance for the little things that you can pay for. You will definitely save money on things like MRIs, ultrasounds, CAT scans. You can save so much money by just paying cash for those things. Yeah. And if we did it on the primary care side, which is kind of the most frequent stopping point for most patients, we could save people so much money.
Well, what is for an MRI, what does an MRI cost if you don't have insurance?
$400.
Oh my gosh.
$375.
That's so
and it
cheap.
depends. I mean, if you go down like an hour outside of Nashville, 45 minutes outside, now you're paying like $350 to $400.
Wow. Here
in Nashville, you're going to pay probably $450 to $500.
Wow. Okay. Yeah. And people don't realize that because, the insurance model is, they're paying the MRI facility $750, $1,000 or whatever.
That's right.
There's that markup. And a lot of people don't realize as well when it comes to the pharmaceutical drugs, these pharmacies, if they could offer the patient the drug at a lower price, if they didn't use insurance, they're not allowed to tell the patient that.
Yeah, I know.
I mean,
it's so crazy.
It's backwards.
It is absolutely
completely backwards. There's a lot of medications like that. I mean, the whole patent process. I mean, I play the patent game personally because we have to. We have biotech. That's the field that we're in. But I don't like it. I don't like the idea that, I've got to protect what my idea, which our idea is, at least, when it comes to the cellular field, there's a lot of other science that goes behind it. And you're trying to find one little way that's different enough to protect, to write IP and to protect it.
That's right.
And, it's a way to make a lot of money, but I don't think it's the best for society overall. The system's not the best.
Yeah, no, I agree with you. I think that's definitely true. It's not the right thing, or at least the right process that could be utilized. We could refine the process, make it better. And, I mean, there's a lot of things on the Make America Healthy Again that I think that we would definitely, the general populace would benefit from. Doctors specifically would also benefit from. And I think that's an important point too, because so many physicians are leaving the field right now. They're very unhappy. I mean, honestly, I can't think of a single person that's still practicing traditional medicine that I know that if given the opportunity that they would continue to do what they're doing, right? And if they were offered an exit ramp of some kind that made logical sense, they would take that exit ramp. Yeah. And
it's because they know they're practicing sick care. It's not health care. It's
sick care. It don't make
a
difference, man. You get beat up when you just see people stuck in mire all the time. You know what I mean? When they're just sort of mired up in their disease and there's no trajectory forward for them. Yeah. And that just sucks, man, because you're not really able to move the needle for anybody.
Well, I mean, think about this. Like, out of all your primary care patients, I mean, how many of those patients are you prescribing 15 drugs to? It's like that started with you. You know, you're
yeah,
not.
yeah, no, nothing.
Exactly.
I don't have any of those.
But then you think about the regular system, there's a lot of doctors that, okay, you're going to take this pill for this, and this is going to be the side effect of this. And all of a sudden they're on 10 or 15 medications.
That's right. Most of which are covering up the side effects from the first 7 or 8, right?
Yes. And I mean, but someone who's actually practicing healthcare would never do that, right?
That's right. That's right. And I felt like that. You know, one of the things I noticed early on was I would do, like I said, a lot of EGDs, and I saw a lot of—
What is the EGD?
Upper endoscopy, right?
Okay.
So I'm looking down through the esophagus into the stomach and then the first part of the small intestine. Typically it's after people are complaining of like upper abdominal pain, bloating, reflux, heartburn. So you're always kind of looking at that esophagus to make sure that the reflux is not damaging the esophagus. That could turn into esophageal cancer over time. And so I would do these procedures on people, and after, I mean, you know, an intelligent person starts to look at the pattern, and you can kind of see it. It's not that complicated. And so you start to see that, okay, most of the time when these people have these complaints, their EGD is negative, right? It's not like I can see or find something on biopsy or pathology that leads me to a diagnosis. So then the natural thought for me was, okay, well then it must not be within the organ that's diseased. The problem must be coming from the outside. And so I thought, well, what's the most common source of where that problem be coming from? It's diet. And so that's when I started putting people on a paleo diet. And there was this lady named Wanda that came to see me, and she was like 62 years old. And she was overweight. You know, she was drinking like, I don't know, 4 Diet Cokes or 5 Diet Cokes a day kind of thing. And she was basically having some bloody stools, constipation, diarrhea, alternating constipation, diarrhea with bloody stools, and then some abdominal pain with reflux. And I told her, I said, look, you just had an upper endoscopy and a colonoscopy like 2.5 years ago. The likelihood that you've got something at your age that has changed drastically in the last 2.5 years is basically nothing, right? Like you got a better chance of getting eaten by a bear wearing red lipstick and high heels in the parking lot than you do of me finding something on this.
Yeah.
And I said, so I'll make a deal with you. What if for 4 weeks you tried my approach? For 4 weeks, I want to ask you to follow certain steps for me. And if in the end of that 4 weeks, you're not better, then we'll do your procedures. How about that? She said, I'm in. So 4 weeks, she came back. She lost 16 pounds. She gave up the Diet Cokes, or she was down to like 1 a day.
Yep.
But the other symptoms that she had gone, right?
Nice.
And so now I had a believer. I had someone who I could kind of start to work with. And so after seeing that a few times, man, it doesn't take long for you to realize the value of that.
Yeah.
And so I got it to where I was treating my clients in my general surgery practice mainly with dietary and lifestyle modifications.
Yeah. I was going to ask you, what does it tell you that the modern healthcare system in the United States doesn't teach diet to medical doctors?
Yeah, we were talking about the training, right? Everything that we're trained to do, and it's funny because you don't realize it, when you're in it. You just don't see it this way.
Yeah.
And then you get out and you start to kind of assimilate all of these pieces together. And for me, it became pretty clear. The training that we have is meant to only use or to treat disease processes with the tools that the insurance companies and the drug companies want us to use. So you don't really get exposed to, imagine if I were a mechanic, right? It's kind of like they gave me one tool chest, but I see other mechanics over there that have different tool chests than mine, Why do I not get their tool chest, right? What's in that box? I want to know what's in that box.
Yep.
And I think that the training part is where we can really fix that.
Yeah.
And also too, in med school, I remember there was a professor in genetics that sat there, and everybody always thinks their crow is the blackest kind of thing, and this guy was a geneticist. So he said, well, when we finally decode the human genome, we'll be able to unlock all disease. And me and a friend of mine kind of looked at each other, thought, yeah, no, that's not really going to work.
Right.
There's too many other variables that are.
Yeah, epigenetic factors. So
the epigenetics alone is enough to say that you don't even understand this, right? Like, and so, yeah, I felt like there's definitely more to disease than just genetics. There's also more to disease than just diet. There's a lot of things.
Yeah. Have you heard of Gerson therapy?
Yes. Yeah.
Okay.
Max Gerson, I think. Max Gerson,
yes.
right?
So my hospital is the original Gerson hospital.
Nice.
So, and it's on TAM Center, our new hospital. We don't talk about it on the website. It's just so controversial. But I talk about it openly, amongst anyone really, because I know it works. Now, it's not an all-out cure for cancer by any means. I don't know of a cure for cancer personally. And we've tried pretty much everything. I mean, we've been on a mission to try to figure this out. But I have definitely seen it cure cancer, and I'm talking about diet alone with Gerson therapy. I've seen specifically with like lymphomas or melanomas, which makes sense because melanomas are one of the most immunogenic cancers. So you see that immunotherapies are working best, the checkpoint inhibitors are working best with melanoma.
Yeah.
And so this epidemiologist that we had working with us, he had been there for 40 years. He did a published study, peer-reviewed published study in the 90s with Gerson therapy versus other therapies for melanoma. And the 5-year survival on that was 36%. That's with a diet therapy. And remember, before immunotherapy, melanoma was a death sentence.
Universally fatal. Yeah,
exactly. So, I mean, I've seen it work over and over. Now, it's an intense diet.
Sure.
And it's one of the reasons I don't even recommend it to people, because how many people are going to drink 13 fresh pressed organic juices a day, do 5 coffee enemas a day, take all these supplements? I mean, our patient compliance was really bad, and I understand why. But I say all that because the idea that diet can actually work, and now we know that the gut microbiome plays a huge role in the immune system and cancer. And so I was thinking maybe that one of the mechanisms of action was the gut microbiome. Maybe it was doing so much change to that. That's what was causing these huge regressions in cancer. And we would see it. You know, sometimes, I mean, the tumors would melt away with the melanoma or lymphoma with just diet.
Yeah.
So, I mean, I say all that to say, yes, diet obviously works, as you're saying. How many different, and that's an intense diet. With your dietary changes, how many people do you think could be treated for most of their illness without medication?
60%.
60%.
Maybe more.
Diabetes?
Oh, 100%. I
Okay.
mean, well, let's take type 2.
Okay, type 2, of course.
Let's take type 1 out.
2.
Let's just focus on type 2. I mean, I believe that type 2 diabetes is 100% a disease caused by diet. But and conversely, we're all pre-diabetic. You know what I mean? Like, if we all sat here and ate sugar cookies and ding dongs every day, you'll be a type 2 diabetic.
What do you think about exercise? You know, so if someone has a good diet but doesn't exercise a lot and their numbers are still sneaking up.
So I think there's 4 factors. I instruct clients 4 factors. So one of the labs that I check on every panel is the hemoglobin A1C. And my speech to clients goes something like this. A hemoglobin A1C of 5.0 or less is just more correlated with longevity. And we can talk about longevity as a lot of things. We can talk about it as cognitive function. We can talk about it as grip strength. We can talk about it as muscle mass. There's a lot of metrics that we can define that by. But at the end of the day, a lower A1C means that you have less likelihood of developing high blood pressure, stroke, diabetes, any of that other stuff. And so there are 4 factors that I think are very crucial into modifying that A1C. So the first one is the amount of carbs that you eat. So like how much you eat, when you eat them, what type of carbs they are, right? So 60 grams of carbs from sugar in a Snickers bar are not the same as 60 grams of carbs from a sweet potato. And so the timing, the amount, and the sort of makeup of the carbs, I believe makes a huge difference. I believe that your stress level makes a difference. I believe that how much you exercise and then how much your muscle mass you're kind of holding on to. So and then the timing of day that you eat those carbs. So those factors all together, to me, constitute the boxes and the pieces on the chessboard that I'm trying to move when I'm lowering A1C.
When do you not want to eat? What's the worst thing you could do?
I would say probably after about 6 or 7 o'clock at night, I wouldn't eat anything.
Really?
Yeah.
Okay.
I mean, it just doesn't make sense to me. Metabolically, it doesn't make sense. I mean, you're not really going to expend any calories past that, you know? And obviously we could think about people who work night shift and we could stratify them out. But as a general rule, most people aren't going to expend any calories after, say, 6 or 7 o'clock at night.
Yeah.
So it's kind of like dumping a lot of fuel into your system with no place for it to go.
Interesting.
And I think there's an energy backlog or energy backup that occurs. And to me, the worst thing, kind of like we probably all know somebody that had too much money and too much time and what those things can do to human behavior.
Yeah.
And I think taking that same thing, put in too much fuel, even a good source of fuel, into a system that's at rest, and you're probably not going to get a good outcome. And look, okay, so last night I had like 2 patties of hamburger with a little piece of cheese on it, and then I had like some sweet potato fries. That I made myself. And that was my supper. And then I went out and I took a 30-minute walk after that. On that walk, I did 20 air squats. Rhonda Patrick, who's a researcher, young lady out there that puts out some really good content, She said recently that walking 25 minutes or so after eating lowers your blood sugar by about 30%.
Walking for 25 minutes or
Walking for 25
Okay.
minutes after eating, yeah, just say within the half hour after
Yep.
you eat, can lower your postprandial blood sugar by about 30%.
Wow. Okay.
And supposedly 10 air squats can achieve the same goal. So I was talking to my client. I said, look, what if we walked for 30 minutes and then did 10 air squats every 10 minutes? So now we're doing 30 air squats. Right? We were going to kill it, man.
Yeah.
Like, you know, so anyway, I've started to get more kind of hacky, if you will, about how we can hack blood sugar.
Yep.
So I don't eat late. I believe that intermittent fasting is good. Another thing that I've seen that will send the blood sugar up is guys now who are trying to intermittent fast. So they're doing a time restricted feeding. They'll eat at like, let's say like 12 and 5 or something, you know? And since they're trying to get in 200 grams of protein, they eat these massive groups of protein kind of at like one big chunk or two big chunks. And what happens is that when you dump or you consume that much protein sort of in your system at one time, your body can only metabolize probably around 40 to 50 grams of that. The rest of it's probably going to get converted to sugar through the liver by a process called gluconeogenesis, right? And then your blood sugar is going to start to spike after that. So I've tried to advise clients who particularly are on the heavier protein side, but then also trying to do time restricted feedings, that don't think of it as two big groups. Think of it as more like 4 small groupings, so that we spread that load out over time and not spike that blood sugar.
Yeah, I just had an A1C come back at 5.8. I was shocked because 2 months before, it was 4.8, and I'm like, how did it? But I've been eating even healthier, drinking a lot less. You know, I normally drink red wine. That's my drink of choice, but I mean, maybe once a week now. And I'm like, what the hell is going on? But stress is high. I have been eating late. And I was just thinking of what it could be that could cause it. You know, I have not been exercising like I should. So I mean, there's a few different things, but I'm like, you know, I think it's a little more than diet though. It's actually the 4 things. Diet's probably the most important. Well, yeah. Would you say that diet is the most important thing when it comes to
I
it?
would, because if you just don't put it in there, then you don't have to over exercise to compensate for the blood sugar rise. Yeah.
I'm going to start the 25-minute walk after I eat at night and do the 10 squats in between. You know, that sounds like a great idea, especially you get a 30% little bump. That's a great hack.
It's a great hack. It's so easy to do. And, you know, the reality is that most of us, we will probably sleep better. You know, I think we'll have an opportunity later on to get into one of the philosophies that I teach clients called the S.H.E.D.S philosophy, and kind of how that works out. And, you know, that stress response will change how you're going to metabolize your macronutrients, your sugar and stuff. And then, but it's also going to affect how you sleep. You know, so if we take a walk and kind of get that stress out, let our blood sugar come down, then you will likely also have better recovery and better sleep at night. Growth hormone levels may go higher, which means you're going to have a better stem cell release and sort of all the benefits that come from growth hormone. Yeah, I think overall that evening walk is not only good for blood sugar, but it's going to pay a big dividend in other areas too.
Now, I saw a video that you did recently that you said that giving blood every quarter you think is really good for your health. And it made actually a lot of sense to me. I never thought of it like that, because you're getting new blood in the system and cleaning it out. Talk about why you think it's a good thing to give blood every quarter.
I was reading a book called Madame Bovary about 4 or 5 years ago. And in the book, a physician is describing, or the author is describing, a physician doing a phlebotomy, or, you know, what they call bloodletting back in the day. And I started to think to myself, at that point, I was reading this, I thought, okay, this has been going on for like hundreds of years. You know, those people were smart. And I believe that we shouldn't throw those things out. So I started to think about that. And then it made me reflect on the times that I've had a male client come back in, because sometimes I recommend phlebotomy because it's needed. And meaning that their hemoglobin is starting to climb, and I'm just trying to prevent sort of any issues that
because of testosterone generally, right?
Yeah, it's one of those things that happens on testosterone. And, you know, there's certain factors that certain guys have that make that more likely for them. But at the end of the day, I started to think to myself, like, okay, there's that group that needs it or will benefit from it. But every time they go get phlebotomy, 100% of the time they come back and say, Doc, I felt better. Like, I felt so much better after I did that. And then I'm thinking to myself, I'm like, okay, so they've been doing this for hundreds of years in rural environments when they really didn't understand all of the mechanisms of it. Every time I send a client to do it, they report feeling better. And our wives, or the females in our life, have a phlebotomy every month for 35 years of their life.
Right.
And they typically don't have as much risk of heart disease and a lot of other bad things that we as guys do.
Mm.
So I thought to myself, okay, what's the link? Why are those three things possible? And what is the link of frequent bloodletting or frequent phlebotomy in that? So kind of as you alluded to, I believe it's more of a cleansing thing. We're sort of taking out some of the old. We're forcing our body to replace it with new. I think that uses up our iron stores. I think it promotes iron metabolism and sort of the natural healthy balance between the blood and the bone marrow. I believe it can rid your body of impurities. Like, so if you're having certain types of toxins in your body, I believe that getting that red cell turnover increase can be good to sort of help rid of your body of those things. And then I also think that there's probably something to the stressor that may put on your body a little bit, kind of like a hormetic stressor, like what we would consider sauna in a way. And I just think that plays a positive role too. So there probably is some sort of neurohormonal mechanism in the background that's playing in that.
Oh, you talked about the Make America Healthy Again movement. What do you think it will take for a mindset shift in society to really allow Americans to actually be healthy?
I believe that most people don't actually believe it's possible.
Mm.
They've been conditioned through watching their parents get on pharmaceuticals and progress down this path of chronic disease and sort of dependence on the system. It's only a small group of people, maybe 5%, that have a window to see outside of that picture, or an opportunity to see outside of that picture. And without, so the reason why at the time, there were three factors that I saw confluencing together that made me think that it was the right time for Compass to exist. The first one is that I was noticing a greater adoption or a greater interest in people, say under the age of like 45 or so, who were not wanting to go the same path as their parents. So first of all, I saw, okay, there's an awareness coming. It's small now, but it will grow. There's an awareness coming that the path that our parents took is not what we want. The second thing is people started to realize, like, I would rather invest money in my wellness rather than my sickness. So, because the whole insurance change that happened, and they're realizing I'm paying more for nothing more that's really helping me. So if I want something to make me live longer, help me live better, it ain't going to be found in my doctor's office. That was also gaining traction. And the third thing that I thought was important was the technology or the factors that can actually help people achieve wellness were actually now starting to be available in an easier way to get it, right? Things like ozone and so forth. And so I saw those factors as big sort of catalyst, if you will, for what's going on. I believe that if there was an opportunity for people to engage and I hate to use this term health coach, because I don't think that a lot of health coaches actually understand health.
Right.
They don't. It's kind of like somebody who hasn't sat in the clinician's chair and interviewed thousands of people. You can definitely speak on health from not having that perspective. But what would happen is that your perspective on health would change if you sat in that chair and evaluated 1,000 people, right?
Yeah,
So
absolutely.
you may have some good advice, but your advice will be more salient and better, and you will refine it once you have those experiences.
Right.
And I think that if we could incentivize a method that people could really have access to somebody who can tell them not what you need to be sick, but what you need to be well. And it's so easy. It's really not that complicated.
Right.
Hard to do, but very simple. And that's where a lot of people struggle. I'm like, look, I'm not going to, the program will help you succeed, but you have to commit to the program. Like I promise you it'll win. I mean, I've got one female client who has lost over 150 pounds by just following a paleo diet.
Right.
And, this young woman was struggling with some female hormone issues kind of at her age, mid 40s kind of woman, and overweight, 300 something pounds. And she's like, man, I don't know what to do. I'm like, I'll tell you what to do. Don't eat these damn foods. Like, just don't ever eat these 8 foods. That's all I want you to do. And yes, that means you're probably not going to go out to eat as frequently. Yes, that means you're going to have more work at home. Yes, that means that you're probably going to give up some things that you would rather eat, but I can promise you, you will get what you want. And 15 months later, that's an average of over 10 pounds a month. She's lost 155 pounds.
Wow.
I mean, I saw her in the office like 2 weeks ago. She looks amazing. It's
That's
fantastic.
Awesome. What does she say?
You know, oh, she's great. She's happy.
Yeah.
You know, her ability to get through her day and feel confident about her life and the relationship with her husband and her family, it's all changed.
What's that like as a doctor that, you know, can give specific advice to their client that really is not mainstream, but it changes their life and ultimately it's going to have her live a lot longer? What's that feel like?
Oh, it's great. But, you know, and I give the power to them, right? I mean, I turn around and give them the credit because it's I said, you did the work.
They did the work, sure.
You know, I mean, all I did was just tell you, here's the playbook, go learn the playbook, right? And if you follow the playbook, you'll win the game.
Yeah.
And so I try to be a cheerleader for my clients. Like a lot of what we do is more about, we're going to help you set goals and set some expectations, and then we're going to hold you accountable.
Yeah.
You know, we become like a health therapist in a way, you know, how can we help you get rid of the negative patterns of behavior?
But I want cookies. No.
Yeah, get it. And I tell them, I'm like, and you are going to want cookies, and it's okay to want cookies. It's just not okay
to eat cookies,
to give into that want. Yeah, exactly. It's okay to want it. It's not okay to give into it.
Right.
Yeah.
Yeah. No, it's interesting. It's one of my favorite things about running CPI and TAM is that, you know, when you support someone in getting better and seeing them, you know, come out the other side healthier or out of pain,
stronger, whatever.
Mental health is better. I don't think there's anything better than it. It's like, it is my favorite thing.
Oh, it is. It's the pinnacle of, like I feel good when I go home.
Yeah.
Yeah. I know that when I lay my head down at night, you know, my mission was achieved.
What is one of the most extraordinary cases you've seen where someone you thought wasn't going to live very much longer and you were able to help them?
Yeah, so there's a guy actually who had COVID, and he ended up on ECMO, survived ECMO.
Wow.
And had bilateral chest tubes. I mean, this guy was really, really sick. Got out of the hospital. And, you know, after I think it was about 9 months, 6 to 9 months, I believe, after he got out, he had gone through all the sort of conventional things that the doctors were trying to do to help him after going through all this. And he ended up finding us. And I basically started the program the way I would with anybody else. And now here we are a year and a half later. This guy's swimming again. You know, his life is back. He did have to use hormones for a while, but subsequently was able to get off of those after his body got back to balance, you know? So not everything that we did with him had a sense of permanence to it. Some of it was temporary, but we did use ozone. We used exosomes, intravenous exosome infusion. Ozone was a big part of it for him. And then temporary hormone replacement. But yeah, I mean, this was a guy who basically could barely walk. Like, you know, he may walk 50 yards or so, and then he's going to have to stop and catch his breath. And now that guy can go swim.
Oh, that's awesome.
I mean, a huge quality of life change for him. And I mean, that's a profound one. But, you know, look, if you take a mom who comes in and says, like, look, for a week and a half out of the month, I feel like I just want to shake, you know, somebody by the shoulders and rip their head off. And you fix that woman in a way that her hormones are a little more balanced. And she's like, yeah, my life is so much better. Like I don't feel angry. I don't feel emotional anymore. I didn't just fix her life.
Right.
I fixed everybody that comes in contact with that woman's life.
Yeah, absolutely.
You know, and everybody around her is going to recognize the change that they see within her.
Yes. You talk about the disease of mediocrity.
Yeah.
Talk about where that comes from and why you say that.
Well, I think it has a lot to do with childhood too, but surgical training definitely puts a little bit of that into me. My grandfather was a German Catholic. We were pretty strict Catholic household. You were kind of told to do things one time and you were expected to do it to the best of your ability. And, you know, no job is sort of worth half-assing it kind of thing and do everything to the best of your ability. And I grew up with that in my head. I carried that through. I wasn't always a diligent student, so I can't say that I did it academically, but when it came to doing a job and taking pride in my work, that is important to me. I try to handle every interaction with the utmost integrity and virtue that I can. And so, and if I'm going to go train or I'm going to go work out, I'm not going to half-ass it. I'm going to give it my best. And so I took that passion into surgery. And what I found is that it's not optional to have that in a surgical specialty. You must have that. Surgeons are born, not typically made. It has a special, you have to have a special type of mentality and thinking process and ability to adapt and ability to sort of think differently. And not everyone has that. So from the standpoint of what I saw as being excellence, I believe that there is now a huge drop in what is considered to be excellent in so many areas of society.
Yeah, across the board.
You know, we see people who can barely drive a freaking car and change lanes, and they don't, and yet they want to go online and lecture us about how we should be raising our kids.
Right.
You know, or we see people who are grossly overweight, binging on being broke, trying to give either health or financial advice to people. And I just don't think that that's the right way.
Or telling, telling us that Elon Musk just got lucky, or
dude.
Yeah,
that's why the judge from Maryland rescinded all of his bonus options that he had, because he just got lucky.
He just got lucky. Yeah. He hit these crazy wild goals, and nobody thought he could hit them when he made that deal, by the way.
Except him, maybe. I think I have to believe that he did.
Sure,
right?
he did. But nobody else. And that's why his board was like, if you want,
sure, if you could do it, go right ahead.
You can make 10x all of our money, then you can have X, Y, and Z.
This is the same thing with Trump, right? Like, they got paid back their money. There's no crime here, you know?
No, it's unbelievable. I agree. There's a disease of mediocrity. I will say this, though. I don't think that there is any time, at least in my lifetime, where it's been easier to be successful, because you have all these weak men out there.
Absolutely.
We're competitive guys. We, high testosterone. We're fighters. Those type of things. We see it innately, and we see it. We understand what's going on. You got all these weak ass men. And, we're nice people. We're not going to hurt. But, we will run over some of these weak men.
I'll get the deal before you will, man.
Absolutely.
That's just the way it is.
It's never been easier to be successful.
That's right. I mean, I've got 14 and 16-year-old sons, and I've told them, I'm like, if you just show up as half a beast.
Oh, a beast.
You will win it.
Yes.
You're going to kill it. It's not that complicated, because the bar is set so low now.
Yes.
We had some work done on our house. This guy came in. I mean, and I'm not saying he did a bad job, but there was some mess and stuff. And I just told him, I'm like, look, this is a reputable guy. He did a decent job for what we paid him and what he promised to do.
Sure.
But at the end of the day, you can see where if you were a little bit more detail oriented, if you were a little bit more customer savvy, how you could charge more money and get a better, you know what I mean? And so, I think, and so when I look at the disease of mediocrity, what I'm most concerned about is how that's going to affect healthcare for you and I, right? Like, what's it going to mean if we do need to have access to that conventional healthcare system? And here's what I'm hearing from people that I know who are still training doctors in the hospitals. I'm hearing that first-year surgical residents are having trouble closing a wound. I'm hearing that you don't have to have, they only have pass-fail tests now. You don't actually have to, when I was in training, if I got a certain score on my test, my ASVAB test, not ASVAB, ABSITE test, or if I did not do well on my USMLE step 1 that I was telling about, you weren't getting into a surgical residency.
Wow.
Unless you were in the top 10%, you weren't going to get a surgical residency. Well, now, the reason, look, I know what I'm going to say may kind of upset some people, but in the hospital, there's a hierarchy like there is everywhere else. If it's like going into a UFC gym. There are guys who are on the card, ranked as top level fighters in the world. And then there's the amateur fighters, right? Well, in a surgical world, or in a surgical kind of atmosphere, we are taking care of the most complicated problems typically in the hospital.
Yeah.
And you become very good at that. You're also expected to kind of start out at a higher level. You're basically an internal medicine doctor who can cut and operate and sew, right? So at the end of the day, we hold ourselves to a higher standard. And in the hospital, when you deal with the more complicated problems, you get really good at dealing with them, and you get good at solving problems. And I just think that now we're taking a generation of people who are mediocre at best. Their expectation is mediocrity. And now we're not giving them any benchmarks where they have to you have to make in the top 10% or you're not getting a surgical residency, period.
So you're saying that currently you don't have to be in the top 10% to get surgical residencies in the United States?
Well, my understanding is that many medical schools have abandoned grades. They're just going to a pass-fail philosophy.
What?
Yeah.
medical schools have a banded grade, so you could be a 70 and pass?
And you get a pass. That's right. And see, back in the day, that wasn't how it worked.
Wow.
Yeah. I know a young lady who's 26 in medical school right now. It's all pass fail here in Tennessee.
Pass fail. What can you say what medical schools?
I'd rather not.
Okay.
But
fair.
yeah, but yeah, I'm like, how do you know who you're competing against? You know what I mean? Like, how do you know what you're setting yourself up for if all you're getting is a pass fail? I mean, that's just, to me, it's just asinine. You know,
I'm shocked about it because you should know where you stand within a grading system, not pass fail. I mean, you should know if you're a D student, you know, you're probably not that good of a student. You're passing.
you got some work to do.
You got some work to do.
Yeah.
But if it's pass fail, like how do you?
You don't know. And so now let's put yourself in the position of the prospective employer here. How do you know who you want on your team?
Yeah, that's a good point.
You know, and I say that because what I'm looking at is that, I mean, listen, I've sent interns home, okay? Because I can do the job of the intern in a quarter of the time and do it better.
Right.
By the time I'm a chief resident, I can do everything that you can do and a lot more. And so I would send interns home. I remember one time my program director showed up. He's like, "Where's the intern?" I'm like, "I sent him home." "You sent him home? What do you mean you sent him home?" I'm like, well, I'm not going to babysit. I'm not here to freaking babysit people. Like, if they're going to make my job more difficult, I'm just going to send their ass out of here. So, but yeah, I mean, they show up with this expectation. And I'll give you an example. This one surgeon was, he went into the operating room, and normally in the years past when I trained, if I were taking over, let's say you're a vascular surgeon, you have 15 patients on your service, you've been caring for these patients. Some of them are near discharge. Some of them are maybe going to get surgery tomorrow. And over the weekend, we were transitioning teams. So the resident that you were working with is going to be replaced by a new resident. The way that process worked in the past was those two residents would get together and they would have a pretty lengthy process called sign out. The really good ones would go bed to bed and work with the other doctor and be like, "Okay, this is Mrs. Jones. This is what we're doing. Here's where we are. Take notes." And then they would go through all the lists. So they knew. So on Monday morning, when they showed up to work with that doctor, they knew everything about everybody and what was going on because it's their job to manage all of their care. Well, on this particular day, the residents on the service had changed, and the doctor shows up in the operating room. Okay. So the first time this resident meets her attending physician is after she's already gowned and gloved in the operating room. We would have been escorted. They would have told us to leave. I don't know who you are, but the first time that I see you, you show up in the operating room thinking you're going to scrub a case. Get the hell out of here. Like, right. You didn't make rounds with me. You didn't make rounds on the patients in the ICU or the floor. You didn't show up and introduce yourself. You have done nothing.
Right.
And yet that's the standard and so when he calls this person out and calls the program director out, guess who gets reprimanded?
He does.
He does.
Or what was the reason?
Because he is overly critical of the residents.
Overly critical.
Right? It's not, how do you say this? We're antiquated.
Right. Yeah. It's just producing weak people. You have to think, on a higher level, that's what they want. They want weak people.
Because they're easy to follow and manipulate,
exactly.
Right? And especially that's why I tell people, I'm like, there's a reason why they want more nurse practitioners and PAs. Nurse practitioners and PAs order 30% more tests. They order 30% more medications, and you can pay them less. So if you're a hospital or an insurance company, who would you rather have? People who are going to order more tests and meds? Of course, because that's how you get paid, right?
Right.
And by the way, we can pay you whatever, 2/3 or whatever, half of what we can pay a physician.
Right. Wow. Yeah, I didn't know that they were on a pass-fail system. That's scary.
It's totally scary. And I mean, there are definitely, I want to say it's either UCLA Medical School or Stanford. I can't remember, but one of those is considered to be the most woke medical school.
Yeah.
And I mean, it is absolutely terrible, the quality of physicians that are coming out of there.
I think it's UCLA.
Yeah.
I think it's UCLA. Yeah. They are an extremely woke medical school. I've got to interact with some of the people out there on the West Coast, and yeah, Stanford's actually really good. At least from the doctors and scientists I work with.
Yeah.
But UCLA, meh.
Not so bueno.
Not so much. Not so much. Their philosophy too. It's like they throw common sense out of the door with the wokeness. I mean,
yeah.
We want the best when we're talking about doctors. We want the best.
The best fighter pilots, right?
You want whatever. The best. Yeah. You don't go into surgery and say, you know what? I want a mediocre surgeon. Yeah. Whoever has gone into surgery asking for a mediocre surgeon. You go to surgery, you're like, I hope, oh, this guy is good. You're like gassing yourself up. Like, oh, he did this here and he did this here. And so-and-so got his surgery from him. Well, that's what you want. You don't want a mediocre surgeon. Anybody with common sense would not want a mediocre surgeon. But they are training mediocre doctors, mediocre everything in this world, it seems like.
That's right. And it spills over into regular society. I mean, I see people who can barely manage their own affairs, and yet you want to dictate terms to the rest of us.
Oh.
I mean, during COVID, I had a lady tell me that she was an expert on masks because her husband had been traveling during the pandemic. I'm like, lady, I'm a freaking surgeon. I've wore a mask every day of my life since 2003. Okay. Like, I know all about, do you think I wear that mask to protect me from you or you from me? Like, you think about that for a second,
right?
You sitting at home behind your keyboard looking at articles on MSNBC or CNN doesn't preclude you to have a great experience that allows you to dictate to other people what to do.
Yeah. Well, you think about with COVID, I was one of the first people online to really speak out from breaking down the data level.
And it was there, all right?
It was all clear as day, clear as day. The first thing that I found interesting, I was following a group of epidemiologists from Oxford, and they had a whole different model than the I forget the other guy that was in England. That was the imperial model. There's an imperial model, and then there was the Oxford model. The Oxford model in March of 2020 showed a 0.026 mortality rate, which is about what it is. It was almost exactly correct.
Yeah, that's right. That's right. Which is about half of what a bad flu season is.
Right. It was like, oh, well, here's and there was a cruise ship that everybody on the cruise got COVID, and you could pretty much see and just do the math yourself how it was going to pan out. And this is back when they were saying 4% of the people were going to die. 4.2%, I think is what they started with, or something like that. Then they were like 1%. It's going to be 1%. It's like, oh my God, 1%. And you're looking at these numbers from this cruise ship, you're like, You're looking at the Oxford, and you realize that these models are only as good as their assumptions, and they are just assumptions. Assumptions are not facts. So
that's right.
Either one of these models can be wrong.
That's right.
But they were preaching, trust the science, trust the science. Fine. I do trust science, actually. But I understand when the science is based on assumptions, it's not the science people are thinking of.
Yeah.
They're like, well, this is what this paper says. Yeah, but this paper is based on assumptions. And by the way, I don't agree with the assumptions.
That's right.
That they're using.
And that's why I told this young lady, I said, what you are failing to recognize is that in order for you to properly interpret scientific data and to read a paper, there's more than just the ability to read.
Right.
You have to understand what they're trying to study. Mm-hmm. Did they study the proper metrics at the same intervals that they should have?
Right.
Did they study it in the right way? Because they could have got some bogus test that doesn't actually pick up or has a high false negative or false positive rate. Did they study the right cohort? I mean, I've seen cancer studies on people who are over the age of 75. Okay, that's interesting, but most people who get cancer aren't over the age of 75. Mm-hmm. So if we look at it as a demographic study, it's not really applicable to most people.
Right.
And so no one who was out there, the lay people who were trying to spew these statistics and talk about trust the science, and mainly what I'm talking about now is like these reporters who just get some kind of headline, from somebody.
Right.
And turn it around when they really didn't go back and read the data, look at the data, look at the, the information, because it was all there. It was all there.
Well, okay. So let's do a little exercise here because I think we probably think a lot alike. Let's say you get numbers from New York City. This is, I think in late April, early May, we got the numbers from New York City of those who have died. If you look at the age groups of the death, so you get the numbers, they say, oh, this is how many people died. The first thing that you and I are going to want to see is
how old were they? Age. Yep. Let's go by decade probably.
Yes. So now you see a breakdown of age. And if you notice that only 5 people out of 25,000 under the age of 40 have died, what does that tell you?
Yeah, that most people who get the COVID under that age group are not going to die.
Yes, and so what I did, I was getting ready to interview the head of the coronavirus task force in Davidson County, and this is early in the whole COVID thing. And I did not want, because the city was shutting down event venues, and I was just trying to be a little careful too, because I was in some trouble financially. It was a really bad time for me. But I'm interviewing this guy, and first thing I thought was, what are the odds of me getting in a car accident this year? And I had a higher chance of dying in a car accident this year than if I got COVID.
yeah.
And I said that to him. And he's like, well, I got to fact check you on that one. I was like, fact check me, but what does that tell you? And he's like, oh, you know, but they didn't want, like, so you take those things and you ask those questions and you have these people in public health that completely disregard the common sense. When you break it down like that and you think about that, if society knew under the age of 40, hey, I've got a better chance of dying if I get in a car accident than I do of getting COVID this year, like, it's going to bring down a lot of anxiety across the board. Why wouldn't they want to do that?
Yeah, well, because you know, fear is the way to get people to be manipulated and do what you want them to do. Coercion, right? One of the easiest ways to do that is to instill fear in somebody, especially the fear of death. And then if that doesn't work, because that didn't work the first time, so then they started to threaten you with your job. If you don't take this or you don't do this, we're going to take away your livelihood. So first it was, if you don't do this, you're going to die. And then if that didn't get you to do it, then we'll threaten your, you know, your financial sovereignty.
All right.
No, I look, I agree with you 100%. I mean, I'm not aware of a single person that we treated with ivermectin and or hydroxychloroquine that actually ended up going to the hospital, let alone die.
How many people do you think you treated?
4,000.
Yeah.
Something like that.
Yeah, you're beating the odds.
Yeah. It was pretty good. Yeah. So, I had a couple people who started, and when I say that, what I mean is specifically like early treatment, right? Like within the first 3 or so days.
Not once you're in the hospital.
Yeah, that's right. Not people who showed up 10 days later or whatever, when they already kind of started to go down a slippery slope. But I mean, look, I 100% agree. I think that this is that mediocrity thing again. It is the acceptance of less than excellent. It is the, you know, and I too believe this is kind of that, you know, weak men create hard times create strong men kind of thing. I think that what we have is a bunch of weak leaders. And I mean that not necessarily in political office. I mean, we have weak leaders at state government bodies, such as the Tennessee Department of Health, right? The lady who was running the Tennessee Department of Health.
Shelley Fiskus.
Back in COVID, though.
The vaccine lady?
Yes.
Yeah, Shelley Fiskus.
Shelley Fiskus, but there was another one. What was her name?
Yeah,
she's the pediatrician.
Yeah. I don't
works
know
for
her
West
name.
Tennessee Health. It doesn't matter. Anyway, the point is that ineptitude and that sort of incompetence and lack of respect for for anything other than their opinion. I think that they hold themselves in such high esteem.
Yeah.
A lot of them need an ego check, you know.
They really do. It's sad because so the reason I knew Shelley Fiskus, her husband was my wrestling coach in high school.
Okay.
And I had immediately, and she's the one that
Lisa Piercy's who I'm thinking of. Sorry.
Okay. Yeah. And Shelley though was the head of vaccines in Tennessee. And we obviously did not agree on pretty much anything.
Yeah.
But I like Shelley as a human, her husband, great wrestling coach, you know, great people. But, you know, Shelley really believed what she was saying.
Yeah.
And I couldn't believe, and I watched a lot of interviews and things like that. I didn't want to debate with her personally, but I really believe that she believed it. But I think she had these blinders on where, you know, she's plugged into this system. She interprets data. If you read these research papers, I mean, their methods on the vaccines are bad.
Bad.
It's
yeah,
bad.
It's
It's a bad I mean, you can see right through these methods that they're doing.
Yeah.
It's like, well, there's never been. And when someone starts saying in interviews that, you know, she's a pediatrician. She had been a pediatrician for, I don't know, 20, 30 years since I was in high school. And she had said she'd never seen a vaccine injury. I'm like,
if you can say that though, you automatically know that you have to be coming to the table with some sort of bias.
Right.
Like if you can't look out and say, because at the end of the day, I'm a scientist, right? Like every interaction that I have with somebody is about gathering data, formulating a hypothesis, and then doing some kind of test.
Right.
Every interaction is like that. So I'm constantly thinking about what I'm trying to do and how I'm trying to conduct this experiment. And if you approach life from the standpoint, as a doctor, from the standpoint that I know all this and I got it figured out, well, man, I don't really know that I can trust your opinion very much.
Well, and the idea, I never see a vaccine injury. It's like, you know, we make autologous vaccines in my lab. So different types of autologous vaccines. We were working with mRNA since 2017, and the whole COVID thing kind of messed all that up because, well, it just did. I don't think the mRNA was ready for prime time, as in it wasn't meant for 5 billion people. You take somebody with stage 4 cancer, you know, they can take that risk, you know, and on that specific vaccine where we take a piece of their tumor, we do whole exome sequencing, find specific antigens that we can attack, use wrap mRNA in a lipid nanoparticle. That makes sense. But 5 billion people, you know, everybody get this vaccine with this spike protein we've never heard of. But even I know that I've always known vaccines definitely cause injury to some group of people. And when you hear people say, well, I've never seen it, like, maybe you're just not looking. That's because
called willful neglect.
Yeah, exactly. They're not looking. And I believe she's a good person. I really do. They're wonderful, like, humans, like great people, but completely blind to possibility outside of their belief.
Scope, yeah. I look, I know people like that too. I mean, I have colleagues who I did residency with, went to medical school with, who have still to this day will, even despite all the evidence now that's out there, they will still maintain that you should get a vaccine or you're a bad guy. They will maintain that, you know, we should have locked down and all this kind of stuff. And I just don't get it. I mean, I do not see that. I just can't go that route.
Well, and the whole mask thing, I mean, if you remember, I believe it was late February, early March 2020, Fauci came out and said, oh, you don't need a mask. They don't work. End of March, he's like, you got to wear a mask. And then think about the division that the masks cause. We knew for 100% certainty that cloth masks didn't work, and they probably actually caused more of a risk. But put your mask on, you know. And then, you know, you go up to the surgical mask, and then you go up to the N95. And the N95, by the way, people are using them, you know, for a month straight.
Yeah, and they're not fitted properly. They don't even work. They don't know what they're doing.
Yeah, and it's like, it's insanity to me.
Yeah,
that so many people went along with this. And Cochrane, which is the top meta-analysis publication, Cochrane came out with a report just probably a year ago or so, saying that masks don't work. They don't work. But we knew this the whole time, yet we're being ostracized and attacked for speaking the truth. Was that your experience?
Oh, it absolutely was. I mean, so I came out in probably maybe 8 weeks or so after this. So I'm guessing it was probably around the middle of May that I came out with this video. And I kind of outlined then what I thought were going to be the steps that this was going to take, meaning that at that point, what I knew is that this was a coronavirus strain. Obviously, I'd taken virology in medical school, so I knew what the backbone of coronavirus was and sort of how it behaves. And then, and I came out with this video. It's probably like 90 seconds long. I said, look, here's what's going to happen. There's going to be multiple mutations of this virus, right? Because this is what coronaviruses do. They mutate probably on that course of every like 90 days or 120 days or something like that, 150 days. And so it's going to mutate. So there's going to be multiple strains. By the time they come out with a vaccine for one strain, another strain will have evolved, and then they're going to pioneer a vaccine from that. So I said it's going to be a rolling series of inoculations that they're going to try to get you to get. Most respiratory viruses, by the way, as they mutate, become less virulent, not more. They burn out over time. And so usually with subsequent variations of the virus, it becomes less dangerous.
Right.
And that's exactly what we've seen. So, and then I told him, I said, and the vaccine's not going to do anything for you, right? Because by the time you get it, the one that it was geared for is already gone. It's not going to be around anymore, or it's going to be around in such low, numbers. It's not going to matter. And instead, I focused on what we were seeing, which were what predictors do you have of a high mortality and when should you be concerned? So I was like, if you're a male, because it was worse in guys, who had a testosterone less than 450, who were overweight or type 2 diabetic, who were deconditioned, like meaning they didn't work out, and their vitamin D was low. I tell them, I'm like, if you had those 4 factors as a guy, your mortality was like 99%. Obese, overweight, diabetes. Yeah, I used all that. I never went into a guy's house that was really sick and saw them that looked like they worked out. Every one of them had simple little noodle arms. I'm like, when was the last time you did a freaking push-up, dude? Like, you're not doing... You believe that the absence of you taking medicines and crap every day means you're healthy.
Right.
And the reality is that you ain't healthy at all.
Right.
And this virus just kicked the shit out of you because you haven't done anything else.
Right.
Yeah.
What does it say to you that, what does it say to you as a doctor that the healthcare community was telling people that natural immunity or having a previous infection, natural immunity, didn't matter.
Oh my gosh, Ed. This is so frustrating. Like, we were vaccinating pregnant women. You know, I've seen at least 3 pregnant women who have developed problems after the vaccine while they were pregnant. And one of them, I asked her, I said, basically what happened was, I said, how did they get you to get the vaccine? She said, well, the doctor came in and apparently the doctor had been over at the hospital and the lady was in the office. So the client is sitting in the doctor's office. The doctor comes in after leaving the hospital and says, you have to get this vaccine. I just had a lady over at the hospital who now died because she got COVID. And so I don't want that to happen to you. You got to get the vaccine. And so she goes, so I took it. And I said, well, wait a minute. Did you bother to ask her, like, is this lady 32, 5'8", 125 pounds, 18% body fat, no medical issues, works out, exercises, eats healthy? Is that because if that lady in the hospital was you, then I could understand why maybe we could make a correlation. But my suspicions is that the lady who died probably wasn't like you.
Right.
And so you can't make that comparison. But yet that is exactly what happened. It's just what you were using a while ago. It's like we're talking about people who had really no experience, no background in telling us what to do.
Right.
Because maybe, and I know I don't mean to be rude about this, but I just think it's true. You know, and I like, look, Lisa Piercy worked as a commissioner of health here in Tennessee, but she also was a big person over in the West Tennessee health system. I know when she was working at West Tennessee Health that she still did clinical duties, but it was a smaller part of her time. And so I think that when we allow people who don't practice clinically to make decisions, and this is where I was going back, where it's not only the levels in the government. Like, look, the American Board of Surgery just allowed doctors in the U.S. to perform gender-altering surgeries on children with no data to back it up.
Right.
If I went out there and started taking out appendixes with no data, right, and no appendicitis, I just want to start taking out appendices to see if we can prevent a problem down the future.
Well, you could call it gender-affirming surgery. They'd be all for it. You could take out an appendix for
call it that, and I would get,
like,
and I'd probably get paid more money, right? Than the $650 that I got paid from Blue Cross.
You have to dye your hair blue, though. But yeah,
that would be good. But it's just the same group of crowd that seems like they're so locked in on ideology, rather than being able to modify your opinion based off of what comes down the path. I like to think that I'm a contrarian, meaning I'm always going to ask, like, what's next? What could be done differently here? What am I missing? How could I see this differently? And I think that a lot of people don't ask that question.
Right.
And it keeps them in complacency and mediocrity.
Well, they just believe whatever they read. They believe whatever headline they have.
And there's no choice to go learn more. Right. They cap it at that. It's kind of like when I tell people the story. I said, you know, in medical school, you dissect out the trachea and you think you learn something about the trachea. And you do, until you go work as a 4th-year resident with a thoracic surgeon who gives you a 450-page book on the trachea. Now, the level of knowledge that you have about the trachea is far surpassed anything that you learned in that first year of medical school through anatomy.
Right.
But you thought that you knew something. You thought that you had a good level of understanding until you got in the room with somebody who really understood
actually
it.
Understands. Yeah, you know what's interesting? There was just an article, I believe it was in the New York Times, that was talking about a government funded surgery for transitioning. And it showed that, well, they didn't actually publish the study because the head doctor of the study was afraid that it would dissuade people from getting gender-affirming care because it didn't show any difference in suicide. It didn't help. And so the doctor was actually saying, and like the quotes, I mean, this is how these people think at this point.
That's right.
Well, I don't want it to have a bad effect on gender-affirming care. I'm like, well, what is science? I mean, obviously, you're getting ready to publish that study, bias as hell.
Yep.
And when it doesn't end up how you want it, you don't publish it?
Yep.
I mean, what is going on? Are we just, I feel like we're living in the twilight zone right now. And these are the type of people that are running our country. These are the type of people that are telling us to get the vaccine or telling us to trust science or telling us to,
that's right, yeah.
Get in line, do what we say, when the science that they're talking about doesn't even back them up most of the time.
That's right. Or they cherry pick certain little details or certain little things in there that kind of make it look like, yeah, maybe there's some shred of evidence for support for their position. You know what I mean?
Well, there could be a shred of evidence. That's fine.
But there's also,
let there be a shred.
there's also a mountain contradicting it.
I agree.
You know?
There's evidence across the board, but we should be able to actually look at the data, teach people to think critically, because I don't buy this idea. They were saying, you know, before COVID, the suggestion was you should do your research. Do your research and everything. You know, make an informed decision for yourself.
Go educate yourself, right?
Then it's like the words were, oh, don't do your own research. That's stupid. Why would you do research when the doctors are telling you what to do, when the government is telling you what to do? And I like, look at the government's track record.
Yeah.
Look at their track record. They've
well
lied to us about nearly everything that's important. They lied us into Vietnam. They lied us into Iraq. They lied saying that the government wasn't reading our text messages and storing our emails. They've lied. All they've done is lie.
All the research that was going on over in Wuhan that we were told was never going to happen.
Well, on COVID alone. They lied about masks. They said that if you get the vaccine, you won't get COVID. Then they said if you get the vaccine, you won't spread COVID. Then they said if you get the vaccine, you won't die from COVID. Then they said that natural immunity didn't work at all, when there was an Israeli study that showed it was 27 times more effective than the vaccine. And they're telling us that we're just supposed to believe them?
You know, and Ed, you brought this up before. You were talking about the immunity, and I kind of skipped over it. But it's interesting that you said that. And I was thinking the same thing. I'm like, so wait a minute. If you were going to see if I needed a booster for, say, like my polio vaccine, you're going to bring me in, and you're going, or my MMR or whatever, right? My rubella titers or something. You're going to bring me in and check titers, because I had to do this before I went into the hospital as a medical student, right? Between second and third year, they bring me in, they check all my titers, and I think I had to get like a varicella booster or something. Right? So I had to go, and I'm not an anti-vax guy. I'm like you. I'm like, I believe that every medical therapy has a specific crowd or use, and we need to figure that out.
Right.
And as you said, in someone who's a 70-year-old or whatever, maybe it's a younger person, but they have an end-stage disease. Well, then let's let them make whatever choice they want.
Absolutely.
Because at their stage, we should allow them to try anything that could potentially help them.
Absolutely.
But I agree with you. The natural immunity thing went out. And if you were looking at that from the standpoint of every other disease process, not COVID, but something like MMR, you know, or tetanus titer or something like that, we would consider those results to be valid and scientifically true to determine whether or not we need a therapy. And in this case, if you had a titer that was high because you got natural immunity, well, that wasn't good enough, even though it was good enough in every other sector. And it's mind blowing.
Well, and the medical doctors that supported this were ridiculing people while committing malpractice.
Absolutely.
That's exactly what they were doing. It's malpractice to say, oh, well, you know what? You still need to get the vaccine, even if you just had COVID.
They were still giving people remdesivir, even though they knew it was killing people, you know?
Oh, man, that's a whole other one.
And I think about, I said this several times to clients as this was kind of unfolding. I said, across the street, you know, my office is kind of close to St. Thomas West. And I said, across the street over there is anchored the largest not-for-profit healthcare center in the world. Ascension St. Thomas is the biggest, as far as I know, the largest not-for-profit healthcare center. I said, so imagine if the medical staff of that place on day one of this, if the true medical staff director had the balls to say, you know what, this smells bad. I don't really believe we should do this. Like, I'm not keeping people out of the ICU. I'm not giving remdesivir. I'm not going to vaccinate these nurses. We are not, as a medical staff, we are not going to do this. And if you force us to, we're going to walk.
Right.
And if one doctor had the cojones to stand up and say that at the largest hospital, I truly believe that there would have been a pause on behalf of other systems, and mainly because the doctors would have seen a group of doctors standing with unity. And by the way, if you haven't figured it out, doctors are probably like the most disorganized group of dysfunctional individuals like in the world. There's not a lot of cohesiveness.
Yeah.
Doctors don't typically stick together very well. But man, if you could have got that done, if there was one uniting physician who said this does not need to happen, especially at that institution, I believe we could have altered the course.
Well, there were, though, a lot of physicians that said this is bullshit.
They just weren't in positions to hold that power.
Yeah, they weren't in power.
Yeah.
But the ones that did, they were, I mean.
Well, and I got censored, right? Like we were saying that before. I mean, when it came out in May.
Didn't they threaten you as well?
Oh, yeah. So, you know, I released this video, right? And then it's like 2 months later, we noticed that we were running some Google ads. We're spending like, let's say $4,000 a month on Google ads because we kind of keep this thing running. And then all of a sudden our ad spend goes to like $25. We said, wait a minute, what happened here? So we start looking in and you're like, okay, well, your click-throughs, your impressions have all just kind of plummeted. So we get on the phone with Google and we're like, so can you explain to us like what's happened? And essentially they just said, look, you're shadow banned. We don't agree with the content that you put out. I had some stuff on stem cells, regenerative orthopedics, ozone, blah, blah, blah on my website, right? So as soon as they saw like my YouTube video or my Facebook video that went out, they then searched everything else and they shadow banned us.
Yeah.
And they said, we're not going to tell you can't run ads. We're just going to put you on page 600 and something so that nobody ever sees you. So we got shadow banned then. That was really more about our website and some of those backdoor things. We survived all that. And then fast forward to last year, 2023. So we kind of stayed under the radar for a couple years after all that happened. And then we had a group redo our website. And then in July of 23, we ported that website over to a new hosting service. Within 6 weeks of that new website being uploaded and made active, Google contacts us and makes us take down our weight loss pages and I think it was our stem cell pages.
Wow.
So, and then 6 weeks after that, 4 or 8 weeks, somewhere in there, Square contacts us, made me take down my Lyme and autoimmune disease and weight loss pages.
Wow.
So now I've got 2 big tech companies, quote unquote, telling me what I can put on the internet, right?
Right.
And then 2 weeks or 4 weeks after that, Square debanks us. They call us and they say, we're deplatforming you. You've got 30 days to get out of our system. And then whatever money's in there, when we're done, we're keeping it. Like you're done, you're cut off. So that was—
We're keeping your money?
They told us that they had the right to garner our accounts.
Oh, wow.
And I had a friend who unfortunately went through a similar thing. He had, it wasn't him, it was a contact of his.
Well,
and this contact owned a gun manufacturing company. And I think they'd kept something like $1.5 million from them at some point that they'd garnered. And anyway, we were able to get our money, but the point is that I had to put together a scab point of sale system. And then, the level of scrutiny that we get is really, it's tough to say because so much of it is in the background that I can't really like pinpoint or quantify.
Well, it's a tech world. I mean, even I got my Tesla Cybertruck and I love Elon, but I'll be damned if their customer service, it's like contacting Facebook. I'm like, hey, I got to fix this. And they're like, you can't get somebody on the phone. It's some AI little piece. I mean, that's how a lot of these companies work. These tech companies, they don't have customer service. They don't have someone that you can explain yourself to. You're basically a number in a system.
In a chatbot kind of thing.
And, but they have the ability to ruin your life with those type of things. Shut down your business. Say, you're not allowed to do business because you don't conform to what the status quo says you're supposed to.
And that was what their explanation was, by the way. They said, why are we being subject to this? And they said, well, the Google rep told us, they said, we as a company feel like our obligation is to provide the most scientifically correct and up-to-date search results for our clients. And your things like stem cells, hormone replacement, weight loss,
it's scary,
autoimmune, Lyme disease, it doesn't fit that narrative for us. So you're not scientifically proven, basically.
I mean, who gets to say what's scientifically proven or not? I mean, like, it's like the thought police. You have to think this way or you don't get to participate in society.
That's right. And that's what RFK Jr. was saying last week. He's like, the left wants censorship. The Democratic Party wants censorship because they want to be able to control the narrative. And we've already seen what that does through COVID. We saw how that probably ended up killing a lot of people unnecessarily and disrupting a lot of lives, jobs, and family disruption.
Of course.
You have no idea how many people have come in my office and said that their family has been through tremendous heartbreak because somebody won't let them come to a wedding because they don't want to get a COVID vaccine.
Oh, yeah. I had my business partner, Scotty. His dad said he couldn't go to his mom's funeral because he didn't get the vaccine.
It's hard on people, man.
Scotty went anyway. He's like, "You gonna beat me up, Dad?"
Like, we're gonna fight.
Yeah, because that's I would fight over that one. My dad would never say that, but it's like the idea that it pitted family against family, and especially you think about guys like us, we're not stupid. We've done our research. We're logical. We can see both sides. We understand why people feel the way they feel. And
we can hear opposing arguments and entertain them.
Exactly.
That's a critical part.
Yeah. I mean, I get the argument. I could argue their side. That's fine. I could go there. But, to have guys like us shut out and to be called, wacky.
Yeah.
It's like, really? Well, we're the wacky ones. Like, we're the ones that are really healing people.
Yeah.
I mean, we're actually healing people with things that science, mainstream science, says aren't real. I mean, I'll never forget the first time I saw a giant tumor in somebody's neck go away. We were injecting Coley's toxins in it. I don't know if I've ever talked to you about Coley's toxins.
No, I haven't heard this.
Okay, so I did a documentary on this a few years ago. So William Coley is considered the father of immunotherapy.
Okay.
So in 1891, he was at Memorial Hospital, which is now Sloan Kettering, and he had a sarcoma patient.
Okay.
And he amputated her arm thinking that was going to stop the spread of the cancer, and it didn't. She died about 6 weeks later. Sarcoma spread, and it really upset him. So he went through the files of Memorial Hospital to see if anyone had ever survived a sarcoma, and there was nobody except one patient. And he went and found this patient. It was like 7 years later in New York City, Manhattan, brought him back, still cancer-free. And it turned out that when the patient had the sarcoma, he got an erysipelas infection and almost died of the infection. But when he survived the infection, the cancer was gone. So Dr. Coley thought, well, if an accidental infection can cause spontaneous remission of a cancer, then so should an intentional infection. So his next patient, he injecected with erysipelas.
Yes, and guess what happened?
The
right,
cancer
they got
went
better.
away.
Yeah,
and
so there's got to be some molecular mimicry or something there that's doing that.
Oh yeah, well we know now what it is. But so it happened to a number of patients, and he almost killed a few of them because there's a live bacteria.
Yeah, sure.
So he changed it to a dead bacteria. And from 1891 to 1936, Dr. Coley had a higher success rate treating many cancers than we do today.
Nice.
And so he was ostracized in many ways, fought for years. He died in 1936. His daughter in 1952 founded the Cancer Research Institute, which is now one of the largest immunological research institutes in the world. And them, along with the Society of Immunotherapy for Cancer and Steve Rosenberg at NCI, are the reason we now have immunotherapy for cancer.
Nice.
But it's even in their textbook for actually, yeah, this one right here, Cancer Immunotherapy Principles and Practice. One of my scientific advisory board members, Franco Marincola, is one of the three authors on that. One of their first chapters, it talks about William Coley and the history of what he did. It's not even questionable. So in Mexico at my hospital, we did Coley's toxins in-house. And so the first patient I saw injecting Coley's toxins with a tumor coming out of his neck. I believe it was a squamous cell. It went away. And I'm like, oh, wow. This isn't supposed to
work like that.
This isn't supposed to work. And we saw it a lot over the years. And so, I don't believe any of the stuff I just read and I'm told to believe anymore. That to me is that's true disinformation at this point. Some people might say it wrongly, so it's misinformation, but I think at the higher levels, when they're really suggesting these things don't work, you can't patent Coley's toxins. I wish I could patent Coley's toxins.
Sure, I'm sure. But
it works.
Yeah.
But, you can't patent it. And there's a lot of things like that actually work that they try to ostracize guys like us on when we just want to have an honest conversation with other logical people that actually want to help society,
help move things forward. That's right. And I'm glad you were able to move past some of that by getting, geographic things that allow you to do certain types of therapies, right? And open up those avenues for people. What really makes me angry is that I know there's some big guys that got kind of censored and taken down, Mercola and some other people, McCullough and all those guys that got really hurt by the pandemic. And, but there's a lot of other young, smaller named guys like myself and other doctors that I know that got kind of, sidelined, shadow banned or whatever during all this. And it over time, it has a negative impact for society because we get kind of scared and skittish and it's hard to do things, and you just don't want to. You just can't. I can't sacrifice my whole livelihood just to prove that I'm right. You know what I mean? I'm not in that position in life to do that.
It was like me interviewing the head of the coronavirus task force. I look back now and think, man, I wish I would have just gone
for the gusto, right?
I knew more. I knew more than he did about it. I knew more than him. I wanted to I knew the data like the back of my hand. That was all I was doing at the time because everything was shut down.
Isn't that scary that this guy is supposed to be the head?
He's the head surgeon at one of the head surgeons at Vanderbilt. Head of the coronavirus task force, Jahangir, Dr. Jahangir. Nice guy. And I'm not knocking him as a person, but he didn't know shit. He didn't know shit about vaccines. He didn't know shit about masks. He didn't know shit about overall health, didn't know shit about epidemiology. And I'm supposed to listen to this guy put us out of business?
Yeah.
Ah, it's unbelievable. And we're the idiots. We're the idiots because, you know, we don't have the power to stop them. So they look at us as the idiots.
Yeah. Yeah, we're the simpletons. I get it. Yeah.
You know.
It is how it is.
Sorry. I'm just going off a little tangent. I'm having a little PTSD from those times.
That's good.
Wanting to jump through the damn, when it was a Zoom interview, wanting to jump through, and now I'm keeping my calm. I'm keeping my calm. And
I get it. I get it. And I can only imagine, having been in that conversation and feeling like you're talking to a wall, you know, or a brick wall, right?
I meet with John Cooper. There's like 4 event center owners meeting, and they have us at this hotel and like different business leaders in different sectors in Nashville. And so we're sitting at the table, and the idea that this guy, John Cooper, is running our city, when, I mean, he shouldn't be running anything. Listen, I run a pretty big company, you know, lots of employees, deal with a lot of stuff. I'm a boss.
Regulation, moving pieces, a lot
This
of it.
guy should not be running the bus station down here.
That's the
You know what I'm
mediocrity
saying?
we're talking about, right? Yeah.
It was bad. And we're talking, and he kind of rolls his eyes at me for a second. He's like, well, this is his concern with events. This is what he said. After he shuts us down, this is what he said. Well, I'm concerned that if they have champagne glasses carried on a tray, that the particles could land on them and the guests can drink it with the contaminated particles from the party. And he's serious, a Harvard-trained, like Harvard-educated moron that's shutting us down because he's worried about particles floating in the air and landing on glasses. But, you know, at the city level, there's a picture of him there with the mask on and a bullhorn standing outside. A guy behind him has goggles and everything, and they're marching for Black Lives Matter. It's like we are living in the Twilight Zone.
That's right. It is a Twilight Zone.
It's the Twilight Zone. Anyways, let's talk about S.H.E.D.S. What is your S.H.E.D.S health model?
So it's an interesting thing. I actually just was sitting in my office probably about 4 years ago, maybe 5 years ago now. And I started to think about what are the key areas that if I wanted to influence a client's life in these, you know, whatever, 3, 4, 5, 6 areas, what would those areas be? And then how would I start to strategize out? So what I came up with after couple of variations was S.H.E.D.S. And I kind of make the joke as a kid that grew up in the country here in Tennessee, every redneck or hillbilly has S.H.E.D.S on their property, right? They got a wood shed, an equipment shed, a tool shed, a she shed maybe. But and then those sheds, they're going to put a lock on it and they're going to make sure that the roof is tight because whatever's in that shed is important. And so I typically draw this little house on a paper and I present it to the client and I write S.H.E.D.S in there and on the side going down and I say, this is stress, hormones, exercise, diet, and sleep. That if you will focus your efforts, right, and kind of look at it and say, am I eating this? If me eating this, is it improving my life in any of these areas? Is it improving my body in any of these areas? So I help my clients calibrate their behaviors and their interventions based off of how it's moving the needle in those areas. And if it's not helping one of those areas, then we probably need to maybe put it off to the side for a minute and consider a therapy or an option or a strategy that will help us improve not just in one, but maybe more of those categories. And I believe that if you really kind of address or follow that mantra, so much of what you don't want to happen to you, like hypertension, stroke, diabetes, is going to be gone, right? Just by being intentional.
It's like 95% if they hit those things, they're going to be good. You have some genetic component, but it's not as much as people would like to think.
That's right. And, and I tell people that in the office, I say, look, they really tie their self to what happened to mom, dad. And I know there are certain things like prostate problems. I know I can see the family lineage. Breast problems. I see the family lineage. Obesity. You see the family lineage. Sure. It's not genetic. It's nurture. Right. So I start to discuss with these clients. I'm like, so what do you think is more important, nature or nurture? Nature being your genetics, nurture being the environment you grow up in.
Yeah.
And I'm like, so it's actually nurture. Like the reason why you got gallstones at the age of 25 is the same reason why your mama got gallstones at the age of 25.
Well, and you know what? It could be both too, because you could be genetically predisposed to have X, Y, or Z, but if you nurture,
You can move away from it, or you could move closer to it.
Exactly. So, I mean, yeah, it is. I agree with what you're saying, but a lot of times people just say, oh, well, it's just my genetics, but there's an epigenetic factor that has a lot more to do with things, which is the nurture you're talking about, than the genetics.
That's right. I tell them that the genetics is kind of the loaded gun.
Yeah.
The nurture is what pulls the trigger.
Right.
You know, there has to be another action there that kind of supports that. Yeah, I agree with you. Those that nurture can move you away from disease processes if you have some genetic predisposition, or it could accelerate that. And the epigenetic factors, which I see a lot of, because there are so many people that go through life-changing experiences that change their body. So in other words, let's take childbirth at a late age, for example, in females. Most women are going to transition into perimenopause somewhere between the ages of like 35 to 40. The earlier that the female has her, and this is strictly anecdotal, I don't know that there's a single paper or anything out there that supports what I'm about to say. My experience has been is that if a female has her children, say before the age of like 32, 33, then they are likely to wait another 5, 6, 7 years before they go into perimenopause. But if you have that child, your last child, or the last pregnancy that you had at like 36 or 37 or 34 or 35, you're probably going to have a very quick clips into perimenopause right after that.
Oh, really?
That pregnancy seems to accelerate that imbalance a little bit when that pregnancy is later. If I have a woman who at 28 had her last child, now she's 37, she's going through it at the right time, but it changes when women have their babies a little later.
Interesting.
I think it accelerates that perimenopause change quite a bit.
Wow. Yeah, I didn't realize that. I mean, that's the hormones in women are something that we've experienced.
Absolutely. Yeah.
Every man knows about the hormones in women. No, I mean that, but I say that in all seriousness, I've seen my mom and, a lot of, women in my life go through those things, and balancing them and having a doctor that actually understands how to do that is very underrated. The general practitioner really isn't doing
qualified. That. Yeah. It's sad. I mean, I didn't get any training in medical school on this. I mean, I did in a way because we would do hysterectomies and we did a lot of thyroidectomies and stuff. So I kind of knew on the thyroid side what to do, and I knew all the general sort of principles about hormone replacement and what the natural, flow of a female hormone cycle looked like. And then it became more about how do I use certain therapies to mimic that pattern, right? And kind of keep that there. And then, I mean, the hormones for females specifically, there was a study that came out May 1st, 2024. It was published in the Journal of Menopause. It was on 10 million senior age Medicare women. So all women over the age of 65, 10 million women. They studied them on, I believe it was estrogen plus progestin, and then estrogen alone, and then estrogen plus progestin. Anyway, great article, great study. And what I would say is that for any women who are considering menopause therapy, perimenopause therapy, go and look at that article. The bad name of hormone therapy for women came out of the Women's Health Initiative, which was a study that was done in like the mid 90s and early 2000s, basically using conjugated equine estrogen. So giving women horse hormones. And then when women got bad effects from taking those horse hormones, the geniuses in the room said, oh, hormone replacement therapy must be bad. Well, no, numbnuts. It's that you're giving a female horse hormones, which her body doesn't recognize, and are going to cause some untoward consequence.
Right.
And that was the problem. And that's where the sort of negative connotation around perimenopausal and postmenopausal hormone replacement therapy came in. But once you remove the conjugated equine estrogens and you go back to bioidentical estrogen and progesterone, the data is overwhelmingly supportive that we improve outcomes, right? Reducing cancer, reducing heart issues, dementia, osteoporosis, all of those things go down when we use bioidentical hormones.
So when are you suggesting women go and see someone like you?
This is a great question. And I want to say that this is a kind of a long answer in a way. The first thing I would say is that somewhere around mid-30s, you're going to experience a shift as a female where you will likely have an imbalance of estrogen to progesterone. If you go into your regular doctor, your numbers on the test will likely be normal. Like, in fact, maybe 1 out of 100 will look abnormal, but most of them will look stone cold normal. But what you're really dealing with when you dig into it from the patient's perspective, is typically in the second half of their menstrual cycle, like the week or two leading up to their cycle, they feel emotionally off, they feel angry, they feel despondent, they have heavier bleeding, their timing of their cycle starts to get off, and their libido starts to get low. So now we're dealing with some like emotional and mental kind of like effects, and then we're dealing with libido and then weight gain. So that is a classic perimenopause sort of thing. Then around 48 to 50 or so, something like that, we start to see the true estrogen leaving the body, right? We get an estrogen deficiency. That's when hot flashes, vaginal dryness come in. And so ideally, a woman would come in before we got to the estrogen component, right? We would start to replace them in, say, like mid-30s, early 40s with testosterone and progesterone, which will typically, because so many women go and get, what will happen is that this is a classic thing in my office. A guy will come in and he will look at me and he'll be like, you know, and she's like, I'm sorry. I don't know why I'm yelling at everybody. I'm just so mad. I don't know what's wrong with me. And I'm like, sweetie, don't feel upset. Like, we know what's going on. It's okay. The fact is I'm glad you're here, because if you'd gone to your regular doctor, they would have said, oh, you're just depressed. You got anxiety. Here, take this Lexapro.
Oh, gosh.
So many women at this age group. I want any woman listen to this. If you think about it, ask your female friends. If they're on an antidepressant, I can almost guarantee you that between the ages of 35 to 45, 80+% of them got on it during that time. And the reason they got on it was because the primary care doctor or whoever saw them was not understanding that the underlying mechanism here was a true imbalance of hormones. Because if you look at the panel, it's normal. It's going to look normal. And I tell women, like, progesterone is your happy, healthy hormone. It's typically what improves your mood, makes you feel good. Hair, skin, and nails look better with progesterone. Sleep is better. So progesterone is a happy, healthy hormone. And when you start to lose that, you've got this bloated, bitchy hormone called estrogen, which kind of keeps you on edge. And then you don't have anything to temper that, right? It's kind of like a yin and yang. And so what we want to do is restore that balance. And I talked to a lady the other day. She's like, my world has changed drastically in the last 6 months. Like, I'm not arguing with my family. I feel better. My sex drive is back. I'm losing weight. I'm sleeping through the night. Like, my life is better than it's ever been in the last 3 years. And so then that's one thing. Now, that right there, approaching the problem there, to me, does not necessarily help that woman with all those osteoporosis and cancer and all that stuff going down the road. I think it probably would. But what I believe happens right there is that we're saving relationships, we're saving marriages, we're saving structure of a family. Then as a female gets closer to that menopause where estrogen starts to go, what I know now is that first shift of perimenopause was a pretty small bump in the road. But now that we get to menopause, it's a bigger bump in the road. And the fallout from that, the ripples in the pond, are much bigger, right? And so I can definitely tell you that there's a period of around that menopause where you've got about maybe 4 to 5 years that if we really start replacing your hormones, we can get ahead of all of the disease that could happen because you don't have those hormones, and significantly decrease the risk that you're going to have that down the road. So I think the data supports that about 5 years is kind of the best time to strike with that. And so ideally we would see them kind of like late 30s, early 40s when they start perimenopause. But if not, then let's definitely consider when estrogen starts to go and the hot flashes and the vaginal dryness and that type of stuff sits in, definitely go see a physician at that point then, or see a qualified hormone replacement therapist at that point. Because, and I know we have to use sort of less metrics. It's not like I could go to a woman and say, okay, I'm going to give you estrogen. I want to see your estrogen level between 40 to 60. And by doing so, I'm going to reduce your risk of dementia by, say, 15%. We don't have the quantifiable numbers of that yet. So what I know is that I don't have a level that says that if I achieve a certain level, that our risk of dementia goes down. And so instead, what I have to do is I have to balance hormones based off of the symptoms that the woman is presenting with. So when a woman comes back in and says, yes, I'm no longer having hot flashes, I'm no longer having dryness, I feel more balanced, my skin is good, I don't have a number to say that actually equates to the longevity that I'm looking for, but it's the best that I can do given the situation that I'm in, right? I don't have another number that I can equate that success to.
Something that you do for men is testosterone replacement therapy. And I started doing testosterone replacement therapy when I was about 30. I went to the doctor. It was my general practitioner. Maybe even younger, maybe 28, I think. and I had a lot of injuries from fighting. And general practitioner, I said, I'm lethargic. I don't feel good, a little depressed. And the first thing that I would tell my fighters would be, get your testosterone checked.
Yeah.
And so I told him that. He's like, testosterone? Okay, I'll test your testosterone. He actually called me. He's like, how did you know that? I'm like, well, because it's
common in that group.
It's common,
right?
yeah. And he's like, you have the testosterone right now of like an 85-year-old man. And I'm like, well, then can I have some testosterone, please?
Yeah, because I'd like to have the testosterone of a 28-year-old man.
Exactly.
Right?
And so, but it makes a huge difference.
Yeah.
And what's been your experience when you prescribe testosterone replacement therapy to men?
I mean, I think it's interesting that we, as a general rule, always think of testosterone in men, and we don't, like, while it's important to us, the same things that we rely on testosterone for is the same thing that women rely on testosterone for. So I wanted to, I break this down for the female clients in the office. I'm like, I want you to think about this as a female, and we have the same thing. We have estrogen, progesterone, and testosterone in our bodies. It's just, and as males, it's just that we have a huge amount of testosterone and really tiny amounts of estrogen and progesterone. And females is the opposite. They have huge amounts of estrogen and progesterone, small amounts of testosterone. But the biological actions of testosterone, as it comes to helping you, overcome stress, heal your body, deal with injuries, overcome sort of the stress of the day, and just deal with the regular BS of life, basically. That's what testosterone does. And it does that in men and women. And because estrogen and progesterone don't really do any of that, right? Estrogen and progesterone allow a woman to have breasts and to conceive a child and to birth that child and then breastfeed that child. That's and menstrual cycles and so forth. So I separate estrogen and progesterone and testosterone out. The reason why that becomes important is because if I've got a female who had a breast cancer, who was an ER/PR positive breast cancer, and they don't want to take estrogen and progesterone, but I can still offer them some of the benefits of HRT through testosterone. So I try to separate those out in females, but because I truly believe that the same benefits that we derive, they will also feel increased libido, ability to deal with the day kind of thing, right? And heal quicker. What I see in men is exactly how you led off, right? So if you bring me a young guy, or any man for that matter, but specifically a younger dude, let's say he's in his early 20s or so, and he's got this sort of like depressed, apathetic type attitude, really sort of not really feeling energetic, not really an outgoing type young man, then, let's do 4 things. We're going to get his vitamin D up. We're going to take away video games and computers. We're going to balance testosterone. And that doesn't mean that he has to be on testosterone replacement therapy, because we got other strategies. And we are going to get his ass in the gym. If we do those 4 things, life will change drastically for this young man. And it's huge. It's life-changing.
And I just want to say this, because what you're saying, if he were to go to a regular general practitioner, they would probably put him on an SSRI.
I would agree with that statement. Yes, 100%. And I say that because, at 20 years old, I went through a breakup with a girl, and guess what they did to me?
SSRI.
The same thing.
Yeah.
I took it for 2 weeks, and I was getting like clamp jaw, and I was like, okay, nope, this ain't for me, number 1. And number 2, this ain't going to solve my problem.
Right.
So I was like, yeah, this is not going to work. But yeah, so I think that there's a couple things that happen with guys and testosterone. Short-term results are increased libido, better body composition, better focus, less naps, more energy, more presence. You are present for the day. You're not distracted, off in left field somewhere. You're actually able to be focused and attentive to what's going on in front of you. And then if you take those things and let's follow the trajectory of that client for, say, the next 18 to 24 months, all of those things then turn into that client typically doubling their income 18 to 24 months after starting testosterone therapy. I have that conversation, once a month probably, or something like that, where guys will come in and be like, dude, this has changed my life.
Yeah.
Like my relationships have changed. My routinely I'll hear after a period of time, they're like, I got a promotion at work. I doubled my income, like one promotion, double my income. And I ask the questions like, do you believe that you feeling better and being able to do more at work has allowed you to get this promotion? I don't say, is it because of testosterone? They're like, yeah, absolutely. Like I feel better at work. I show up, I do more, And I tell them, I'm like, testosterone is not like this magic bullet. It doesn't make you go make more money, but what it does do is it makes you a better version of yourself. And so now, instead of like feeling apathetic and crappy and not wanting to make another sales call or being too tired to kind of like go to the gym, you're like, no, man, I'm not going to go belly up to the bar. I'm tired. Yes, but I feel good. I want to achieve this. Testosterone makes you conquer that problem, makes you conquer that issue. And so you go to the gym, you start to show up, you make more sales calls, you do the thing for your wife that maybe you didn't feel like doing before. And now all of a sudden things start to get better and line up, right? And so now you capitalize on it over 24 months, and all those behaviors led to more sales calls, more deals, more money, more fun, more sex, more life, more happiness, more events with their family. Like everything seems to get better. I mean, I think testosterone is probably the most underrated drug in the world.
Yeah.
I really do believe that, for men and women.
Yeah, no, absolutely. I agree. Why do you think testosterone rates are dropping currently in the United States?
A lot of things, man. I think, you know, so for guys like in our age group, I think it's actually the fact that we probably for the last 20 years or whatever, we're drinking out of plastic bottles. And, you know, I mean, we got glass here now today. They take care of you here at the Ed Clay Show. They give you some good glass bottles. But yeah, general rule, we're eating plastics, right? Or plastic fork spoons, you know, whatever. Plastics are permanent endocrine disruptors, right? So once a polystyrene plastic molecule has bound to a testosterone receptor, it is permanently bound.
Really?
And it will not undo that binding until that cell has died and been replaced by a cell with a healthy testosterone receptor on it.
Interesting. Never knew that.
Yeah, polystyrene plastics can irreversibly block your endocrine receptors. Fragrances. You know, I went into a dentist office recently. I'm like, oh my God, I can't even stand to be in here. It's just so much potpourri and cologne and you know, what I'm like, this smells so bad. And young kids, late nights and video games, right? That dopamine surge, all of that late night staying up. I did a video one time where I said the one thing that'll disrupt a man's testosterone the most is lack of sleep. It's not able to recover. If you start not sleeping when you're in your 20s, like I did in medical school, no kidding, you're going to get low T. No kidding. Yeah. If you stay up and push your body to fight and train and hard and cortisol, you're going to burn out, man. Yeah. And I think you would testify.
Oh yeah, no, absolutely. I mean, it's kind of across the board right now. The plastics is pretty interesting because
soap, shampoos, deodorants, same thing, right? All those environmental kind of toxins.
Yeah. Do you have your clients do any detox at all?
I do. Yeah. So in young guys, I kind of get away. I tell them like, okay, no soap, shampoos with parabens or phthalates, right? Avoid plastics, deodorants with aluminum and that kind of stuff. So I make some recommendations around those things for the young guys. I'm sorry, what was your question again? Do I offer detox?
Yep.
Yeah. So when it comes to detox, I want to, as a general rule for the non-sick people, what I mean by non-sick is they're not dealing with like Lyme or mold or something like that. And we're just trying to do like a healthy detox. I'm really big on sauna. Like I think that sauna is probably just for the money and for the time, you're getting a great detox, but you're also getting so many other benefits, right? The hormetic stressors and the heat shock proteins. Yeah. BDNF and, we could go through the whole list, but at the end of the day, I think that sauna is a great thing to do.
Agreed.
And then the main thing is to just stop polluting your body, right? Just to stop taking in the poison,
Have you ever done a coffee enema?
I personally have not, but I have a lot of clients who do.
Man, coffee enemas are one of my favorite things for detox because your blood pumps to your liver about once every 3 minutes.
Yeah.
So
yeah. I mean, in the colon blood flow, well, you may know there's enough evidence to show that even a dose of rectal ozone is almost the same as giving it intravenously when it comes to reaching the gas.
Yeah, well, I've got an ozone generator in my bedroom next to my bed, and I've got it in Mexico as well. And I do it probably 3 days a week. And when I don't, I get a little sick.
Yeah.
So like we were just at a wedding last week, and we actually had 2 weddings in 4 days, one in Florida and one in Wyoming. And the one in Wyoming, it was a beautiful wedding, but they had a wine cellar that was like 100 yards long and a straight line of tables in that wine cellar with very little circulation. And I'm like, there is no way that we're not going to get sick here. If somebody's got something, we're all getting it. So I got back and I started loading up. I knew I kind of feel it the next day even. I'm like, oh yeah. And so ozone will save you.
Yeah.
But I mean, what are your views? Because you do ozone. You're one of the only doctors in Nashville that I know of that does it. And you're all in on it. You have the 10-pass machine, you have the ozone apheresis, you have the direct IV, you have major autohemotherapy. Am I missing any of the ozones?
The ozone dialysis is the only one, which I guess is probably the apheresis. Yeah.
So you do all of those ozones.
That's right.
What is ozone, and why do you use it in your practice?
Ozone, as I would describe it, is a kind of a more potent form of oxygen. It has 3 molecules of oxygen bound together, instead of the dimeric form, which is the O2 that we typically breathe in. Most ozone that we use exists as a mixture of ozone and pure oxygen. So we're basically getting like 99.9% pure oxygen. Usually that oxygen is passed through a glass cylinder or some type of catalytic device, which will then sort of split those oxygen atoms, allow them to reform. And out the other end of this generator comes a mixture of gas, which is ozone and oxygen. And so of those techniques that we use, what we try to do is if we're going to use, we try to get people to use ozone at home when we can. So we have a generator that's made here in Nashville that we sell to people. That
I bought one from you, from my mom.
Great little device, right? It works good. It's pretty portable. It's pretty safe. It's in a plastic case, so you can drop it. It's not going to break it. And then we can get you catheters and kind of train people on how to use that device at home. So we provide a home training program for them. And for a lot of things that can be really, really beneficial, like you were saying, for immune boosting. I treated a young girl one time, a young lady who was 34 years old. She had grade 4 out of 5 cervical dysplasia. They were looking at doing a LEAP on her and kind of removing part of her cervix. She came to me and said, Lee, look, I really don't want to do that. I said, I get it. Let's try this first. I had her do twice a day vaginal ozone insufflations.
What gamma?
23.
Okay.
I typically use 23 around that when I'm doing like rectal or vaginal, just because it won't dry out too much. And so I had her do that twice a day. I put her on some herbal supplements, which are more for like viral load, and one for biofilm breakdown. Like I use an oral EDTA to help biofilm breakdown kind of thing. So she did this for 3 months. She goes back to her OBGYN, and when they cultured it, what do you think they found?
It was gone.
It was gone.
Yeah.
Not only was the cancer gone, but she was back to grade 0 or, whatever, but there was no HPV to be found.
Wow.
Do you think I got a phone call from the doctor asking like, what the heck happened?
What did you do? You just solved a very complex problem.
I get a text from the client going, here's my pathology report. Gosh. Thank you so much. I'm so happy to be here.
Well, I mean, my thing with ozone, and look, I mean, we have the biggest stem cell company in the world. So, that's where I make
that's
my
your money.
living.
Yeah,
that's my, if I had to pick one thing, stem cells or ozone, I would pick ozone.
Yeah.
Because it's an everyday user, man.
Yeah,
I mean,
you can do it every day.
Stem cells are great for what they're great for. Don't get me wrong. I mean, like it's great what it does. But an everyday, how do I stay healthy? Ozone, and you can do it. The box is like $1,000, $1,500. You get an oxygen tank, you get the tubes. You're paying
in for $1,600 or less, right? Yeah,
and it doesn't cost you. It costs you the oxygen tank to rent every month.
Yep.
And you can, if you do ozone every day, like let's say 5 days a week, you will never get sick.
That's right.
I mean, like it's unbelievable how well it works. I just got to stay more consistent. I always say, gosh, I got to do more ozone because I'll travel and I'm in hotels a lot,
That's
et cetera.
right.
And I lose my routine. But ozone therapy, man, and that's one of the things when I first went to your place, I'm like looking at I'm like, oh, he likes ozone. He's got to know his shit because, ozone to me is the most underrated thing in medicine.
Yeah.
I mean,
you can treat so much with it. I mean, you really can. And like you said, it has that with the home applications and then either doing major autohemotherapy or a 10-pass or an ozone dialysis or whatever, whatever terminology you want to use for that. And yeah, it's just profound. I mean, it is really good in terms of everything that it can do for the body. Excuse me, a lot of people worry about herxing. I actually don't see a lot of that.
I can see it with the dialysis because so much.
It is, but I agree with you, right? You would think if that's going to poke the skunk, right, that would be the time that they would herx.
Yeah. And
I just don't see a high incidence of that. So if that's a fear of someone's, like maybe they're going to herx. Now, if someone has a real...
Tell people what a herx is.
Oh, yeah. Traditionally, this was defined as what's called the Jarisch-Herxheimer reaction. I think he was an Austrian-born physician, but he was describing what would happen when you give someone, I think it was penicillin actually, is what he was given to syphilis patients. And so he would give penicillin, and they would have this massive die-off of syphilis bacteria, and it would, cause them to get like a cytokine storm, and they would feel really sick and flu-like, or like they were getting an infection. And it's basically like you're getting the flu, right? A herx is kind of like getting the flu or getting a cold, where you feel kind of crappy for a few hours, and that is traditionally called a herx reaction. And that happens when we give somebody a therapy like vitamin C, ozone, where we're kind of causing like a cytokine reaction or a cytokine storm in the body. And they'll complain of like flu-like symptoms, body aches, headaches, fevers, chills, that kind of jazz. And it usually passes within like 6 to 12 hours.
Oh, yeah, it's not bad.
It's pretty gone. But I tell them like take some Tylenol or stuff, but most people don't actually even have to.
No, the only time that I've got a herx with ozone, it's happened 2 different, a couple days in a row, but 2 different times, both times with COVID. And it was
really,
yeah, I was doing the ozone insufflation, and man, it was rough. I mean, I was being kind of a sissy, but I'm just saying it was rough.
But you could tell something was different than the other times.
Maybe I don't want to do any more ozone today.
Yeah.
Because it was battling.
You knew it, yeah.
But yeah. Worst herx that I've seen is with Gerson therapy. Between day 10 and 14, people get sick for a couple days.
Okay.
And it's like they're a fever, which is you want. You want a fever.
You can need that, yeah.
I think with disease, tell me what you think about this hypothesis. I think a lot of the reasons we have an increase in cancer and a lot of these diseases is because when someone has a fever, we give them Tylenol.
Yeah, I was taught by a pediatrician, an Irish pediatrician. He's like, look, you don't treat a fever or a cough unless it's disrupting something.
Interesting.
And he would be like, you don't treat a kid for a cough unless it's keeping them up at night. I saw a little guy this morning who looks like he's got pneumonia, and I was like, look, he only use the medicine to stop his cough at night so he can sleep. We don't want to stop the cough. That's not the right answer. You got to get this badness out of your lungs, but we do have to sleep. And so, yeah, Dr. Daly actually said, don't treat a fever or a cough unless it's causing an issue. And I agree with you. We treat things too early. We don't let the body kind of develop. And I know another thing, and this may, a lot of people may not kind of agree with what I'm about to say. And I guess what I'm saying is I'm very kind of skeptical about this. I listened to RFK Jr. on Joe Rogan's podcast. I believe it was at the beginning of the year. I don't remember the month, but RFK went through a great, and I believe, by the way, that with his experience and the way he lines things out, I think he is a really intelligent man. And I think he has a lot to offer when it comes to like perspective on the vaccines. So when I listened to that and what I heard from him is that what I knew, which is that, yes, these things have changed drastically over decades from the manufacturer's perspective. Also, that there was not a lot of studies done on harm and sort of like what could happen to immune suppression after we've done all these vaccines in young kids. And I guess after hearing him speak about that, I look at some of these problems that we're getting as we get older. And look, man, when we were in our 20s, you didn't see young women getting endometrial or ovarian or uterine cancer, right? Like that wasn't a thing when we were younger. And now it's a thing. And I'm skeptical about like, why is this happening? I think birth control is a big contributor. I do get concerned about how the newer generations of vaccines could be affecting our immune system because we're not really allowed to question that.
Well, I think all of them, like when it comes to vaccines, and definitely not anti-vax, but a lot of what we do is based on the immune system. Like that's my focus. I could talk.
Even stem cells have the immune component, right? That's a huge
stem
deal.
cells to me are immunotherapy because even if we're doing a shoulder, what happens? We inject it. We're sending the immune system really into
macrophages, all these stem cells.
Those cells are signaling everything to come there. So, I mean, when I look at it, if we're taking 70 to 80 vaccines before we're 18 years old, if we're giving our kids that many vaccines, we have to acknowledge that that's going to change the immune system. You're causing, hyperstimulation, right? So you're creating an inflammatory state to present an antigen through the dendritic cell to the T cell to remember, hey, if you ever see this again, go kill it, and producing B cell antibodies.
B cell producing antibodies, monoclonal B cell.
What is nobody's really done a study on what's the cumulative effect of 70 to 80 vaccines.
I agree with that. That's a great question, right? I would love to know the answer to
I
that.
mean, come on. It's got to be something.
It's got to be bad.
It's
yeah.
got to
Because
be.
I don't think it's good. You know what I mean?
No.
Like, I just can't see that would be a good outcome, you know? Yeah. So I think that a lot of these diseases and stuff that we see, younger cancers and stuff, while I worry about the environmental thing, I know we kind of got off of this talking about the environmental stuff on testosterone, but I think it's actually contributing to a lot of this. And then, you know, if we go back to the testosterone thing, like, man, guys are getting getting lower and lower testosterone at a younger and younger age. You know, they're definitely coming in. I mean, I see so many young kids in their 20s with this, and I try not to put them on testosterone up front, right?
Sure.
I try to do HCG or enclomiphene to get them up and kind of maintain them, because that way I got good fertility and testicular function preservation, and I'm not just allocating them to testosterone for the rest of their life. But yeah, man, the environmental factors are contributing to the decline. The staying up late, stress, I think, is a huge one. And then I do get really concerned about these things, vaccines, and our long-term stuff, especially as it comes up with cancer and stuff.
Yeah.
And I'm not saying don't take vaccines.
I'm not either.
But I'm concerned about what is happening.
We should use some common sense though and say, hey, which ones of these do they really need Hep B?
That's my point. Like, why would I got a call from a young guy as a fighter recently, and they had a baby, and the baby was going to get a series of vaccines. I said, you know, one thing I can tell you for sure is that I would not do a Hep B vaccine.
Right.
Like, especially in a neonate. You know, there's no reason for that. Like, I didn't get a Hep B vaccine until I went to med school.
Right.
You know, and it was because I was.
Why do they give it to them like on day one, right?
Yeah, absolutely.
Why
or
Hep
the
B?
next day, whatever.
Isn't it
yeah.
only sexually transmitted or blood to blood?
Blood. Yeah, all body fluids. Something that a neonate is not going to be in contact with, except it's his mom, dad, or brothers or sisters.
So
right?
if the mom is negative or
Yeah.
the dad's negative, why give them that at that age?
I agree. And, you know, and there's also the philosophy that a lot of people who get Hep B will actually clear it. I say a lot. I think it's probably about 20%, but
Really?
you know, yeah, a certain number of people that get hepatitis B can actually clear it.
I just can't imagine.
And not convert to the chronic Hep B patient. You know?
If you were going to give Hep B, wouldn't you want to wait till somebody's sexually active?
I agree. Same thing with Gardasil.
Well,
right?
that's a tricky one, huh? Gardasil. I mean, I've seen a lot of people die of ovarian and there's a cervical cancer. And, you know, it's tough. Many times it's HPV related.
Yep.
So I think about I had a girl I dated that ended up coming to my hospital and dying of cervical cancer. But, you know, so it hits close to home. But, now here's a but, like, there are some major side effects to that damn vaccine.
Yes, there are.
You know, it's tough. It's not all the, you know, roses and whatever.
Lollipops and gumdrops it's cracked up to be. It's not. And I've told my daughters, who are now, you know, they're both actually 19 right now. I got one that'll be 20 in a couple of weeks. But I've told them, I'm like, if somebody ever tells you that they want to give you a Gardasil vaccine, you better run, not walk to the door. Like, get the hell out of there as fast as you can.
Yeah.
You know, yeah,
it's tricky. You know, one interesting thing to it, I'm not sure the first dose is bad. It's that they make you, because I was looking at the data, they did not, and this has been probably 5 years, so I'm trying to remember, but like, they did not do studies on how many you really need. I'm not sure that you need the 3 that they say you need. I think it might just be 1. Because ultimately, all you're looking at is little antigens. You know, they get that your immune system recognizes.
That's right.
And I'm not sure now. Interesting about Gardasil. We like to use it in our squamous cell HPV positive patients.
Well, because most of those are HPV. Yeah.
We'll inject it right in the tumor.
Yeah.
And
is that how you guys getting success? Like, how's that helping?
Yeah, we do. We do a combination approach, but yes, I mean, we're pretty good at squamous cell HPV positive. We know a lot about that cancer. Not great at curing it, but very good at getting it to go away for a while with very little side effects.
Yeah, and that's like the #1 cancer in men right now, isn't it?
It's unbelievable. Yes. So, you know, men are 7 times more likely to have an HPV squamous than a woman. It's like the new, because we kiss a lot. And you get HPV in the mouth, and then you get it up the neck or throat.
It gets in your tonsils.
It's constant, man. I mean, I've seen so many cases, probably treated, I bet you, over 150 patients.
Yeah, I had a good friend who died just like a week before his 50th birthday a couple of years ago.
Yes.
You know, of squamous cell carcinoma of the head and neck.
I'll tell you something interesting. I'm sorry to hear that. I'll tell you something interesting about that cancer and some other ones. So the off-the-shelf prophylactic vaccines that we give people, a lot of them are good for cancer. There's a lot of data on it, and intratumorally.
Yeah.
So, and the reason you're not seeing it right now as a oncolytic virus is because it's off patent. So they're trying to rework these vaccines to
So that they
be
can be-
oncolytic
I
cancer
see.
vaccines,
Interesting.
but they're basically just some off-the-shelf stuff. So with our new Translational and Advanced Medical Center, one of the new models is we're taking these off-the-shelf vaccines, doing them intratumorally. We're freezing the tumor first.
Okay.
Then we're adding multiple adjuvants to it, trying to create a systemic
Synergistic
response.
Yeah.
Yeah. And, but we're using off-the-shelf vaccines for that.
Well, I can see why. I mean, they're going to promote antigenicity, or they're going to promote an immune response. So
You
that's
got
what
it.
you're looking for. Yeah.
You got it.
Yeah. Interesting.
So, but there's like so much. So yeah, clearly not anti-vax. Actually, doctors know more about vaccines than most people. I guess I would too, just from the line of
Well,
work.
for sure. Yeah.
And, but society likes to put us in boxes these days where you're either anti-vax or you're pro-vax. So to be pro-vax, I have to be for all vaccines. Never.
Yeah.
Stop.
Well, I have to be the way that you define it.
Right.
I can't be the way that I define
Right.
it,
Yeah, it doesn't really make any sense. Or like Gardasil. I remember like really digging into that vaccine, and I'm like, why are they giving multiple doses here?
There wasn't really long-term studies on it. I mean, they didn't follow these women for a long time to see what happened. And just to show you how kind of
you have seen cervical cancer almost completely drop in women that have had it, though. That's
Sure, yes.
positive.
I mean, no doubt, right?
Yeah.
Like, it could make a difference for them, and I'm glad that those women were able to benefit from
Yeah.
it. I would like to think that we could take that and make it so that it helps, a higher percentage of women and harms nobody. That would be the idea.
They could just do vaginal ozone.
Yeah, that worked. I mean, I got at least one case study of that to say that that's true. I had a thought. I don't even know where I was going with it, but yeah, it's just I believe that we got to definitely evaluate where we go with the vaccine schedule in kids.
Yeah.
I just think we can do better.
Yeah, absolutely.
I mean, I don't think we need to kind of force this all at once. And that's what I told the guy that I was advising. I said, look, I'm not saying that things like a measles, mumps, and rubella wouldn't be good. So, I mean, maybe it is.
Maybe not all at once.
That's
but you
my
can't
point.
get it in the United States. I have an immunologist who came to me in the United States like, hey, I don't want to give my kid all this at once. Can you get it for me separate? I got it for him separate in Mexico.
Yeah.
But
Makes sense.
immunologist,
Yeah.
like, come on. Come on.
If the farmer comes and buys beef from you, what does that mean?
I mean, come on. He got it. He understood. Yeah. And that's happened now with 2 immunologists. Another one that, well, I don't want to get too personal, but there's been 2 now. With testosterone, do you go directly into the muscle with your injections, or have you done the with the
Sub-Q
insulin
route?
needle? Yeah.
Like sub-Q or
Yeah,
micro dosing.
yep.
Yeah, I have clients and I've tried both, or all of the above. So I've done both larger injections or larger volume injections sub-Q. I've done micro dosing sub-Q. Both of those, I'm one of the 40% of guys that if I use a testosterone subcutaneous, I get painful lumps in my skin.
Oh, interesting.
So certain guys, and I don't understand the mechanism of it. I actually didn't really go crazy about trying to figure out exactly what's going on, but it creates a little inflammatory nodule under my skin. And from my research and what I've gleaned, it's about 40% of guys that can't kind of do a sub-Q injection. For me specifically, I'm a fan of doing my injection every 4 days, every 3 days or so. So I typically do Monday and Friday, and I will do it in my thigh. And I like an intramuscular injection. I've been doing that for 10 years.
Nice.
And I do a sub-Q HCG that I use occasionally. And then I'll also take oxandrolone or Anavar for about 2 8-week courses a year.
Interesting.
But my testosterone most of my clients I don't have to give them a lot of testosterone. As you know, this misnomer around you need this massive amount of testosterone is quite BS. Actually, most of my clients are somewhere between 120 to 160 milligrams a week.
What do you like to keep your clients? What testosterone level do you like to keep your clients?
If I can see you 2 to 3 days after your after your injection was done, I want to see your total in the 12 to 1400 range, 11 to 1300 range, kind of in that top 20%, right?
I see.
If I can get you 1,000 to 1,200, 1,100 to 1,300, somewhere in that range, I'm happy.
I've kept mine between 800 and 1,000. So you see a bump between that?
I probably would do. I mean, I think that. Well, let me preface this with a little bit of like maybe a caveat.
Sure.
The caveat is that you're probably not going to feel if you're getting great results at 900.
Mm-hmm.
Then taking it from 900 to 1,100 is probably not going to change how you feel that much.
Mm-hmm.
And what I've seen is that the way that the injection is done. So let's say I inject today. What happens is about 24 hours or so from now, your total testosterone is going to reach its peak. And then about another 24 hours or so, half a day or some 18 hours after that is when your free testosterone reaches its peak. So about 2.5 to 3 days in is when I'm looking at the total testosterone coming down a little bit, and the free testosterone should be right about its peak. If I see a peak between, and I'm going off of my scale, what my lab says. So normally on my scale, I think the top range of free testosterone is like 27 or 26. I try to push it a little bit higher than that. I want to see them somewhere between like 25 to 30 in that free testosterone. And I'll have some guys who will hang out in kind of the low 30s number. Yeah. The only thing that happens if you get more testosterone, in my experience, right, is that they're just asking for a little more estrogen issues. And if you're not drinking alcohol and you're not overweight, you're like carrying a lot of excess body fat and eating crappy food, your estrogen typically is never going to cause a problem.
Yeah, I take an anti-estrogen just because, well, my hemoglobin was starting to, I was like 19.
Okay.
And so, yeah, I started giving blood too. And then I saw your video and I'm like, that makes sense. I'm going to give blood.
So do you feel better after you donate?
Yeah.
You notice like you feel like I'm 5 pounds lighter, right?
Absolutely.
Yeah.
Yes.
Yeah. That's the typical thing that guys say.
Yeah. So, but it's interesting with it. I mean, I do the sub-Q. I mean, and because I did not like putting the needle in my hip.
Yep.
You know, it's like, you know, it can be painful or whatever. I'm being a sissy, but I mean, it's like, you know, it is what it is. And, but what got me back on it consistently was the
microdosing.
Like, it's just great. I do it 2 times a week. My levels are between 800 and 1,000. And
I bet if you at that level, I have to say that I do believe that the sub-Q route probably won't get your levels up as high, but it doesn't mean you don't feel just as good. Oh. So to me, there's a pretty broad range at which men are going to feel good with testosterone.
I mean, especially if someone's sitting at 250 or 150.
My God,
if you get above 700, like, you're going great.
They're like God.
Yeah. Yeah. So, I mean, it's, it's interesting though. I mean, people, you know, and I like that you don't just put people on testosterone, because if I do want to have kids, I mean, Laura and I will probably get married here in the next couple of years and gotta
plan,
get some babies. So I'll have to be careful with that one here, you know, but
yeah, I really try to approach fertility with every male client, right? I mean, I've got some obviously that are older like me. I've had a vasectomy. My kids are 20 years old, right? It's not a worry for me anymore.
Sure.
But yeah, I just don't reflexively go to testosterone unless that's the only solution for the problem.
Gotcha. Anything else you want to bring up before we close it out?
You know, I'm really excited about Upgrade Labs. I'm really excited about Upgrade Labs. Upgrade Labs is Dave Asprey's biohacking franchise. So we were talking about red light and sauna. We're going to have a couple of red light charger beds, pulse electromagnetic field therapy, which I think you guys use as maybe in the cancer realm. From us, it's great, you know, for detox and kind of like recalibrating your body. Cryotherapy, OxFit. So we're going to have some artificial intelligence workout capabilities. There's going to be a brain biohacking component to this. So for those people who are watching and are interested in like, what are the modalities outside of things like ozone, hormone replacement therapy, IV therapy, proper vitamin supplementation that are going to be available for me in, say, the next 3 or so years that are going to keep me healthy? I would say the biohacking industry is really going to come around. There's going to be more locations, opportunities for the regular person to kind of get into use some of these strategies that I guess are kind of fringe in a way. Or
are you going to be doing the Upgrade Labs?
Yeah, I'm part of the franchise team that's going to be bringing it here.
Oh,
so
cool.
I'm affiliated with that group.
Is it going to be, are you going to have your clinic inside?
I'm not.
Okay.
What we may do is in the initial setup, we may put a smaller concept of Compass that would support it from the IV component next door.
Gotcha.
When we look for our location, the real estate will have to kind of accommodate that. And if we can find that, that would be my goal, so that we have a a Compass location that provides IV therapy and what we do on the peptide side that would then complement the therapies that are present within the walls of the Upgrade labs.
I see.
But that's a very exciting project to be part of. And
Awesome.
then another thing that we're doing at Compass, which is kind of a stop before people could come to CPI, is our autologous stem cell program.
Mhm.
I heard you recently talking on a podcast about what makes CPI different, the hypoxic nature that you guys grow your cells, and you probably have some other proprietary things that you do that. And I think you and I were talking a couple of weeks ago at that Bulletproof conference, and I said, what we would want to do as a company is offer clients a solution when they may not be able to use what CPI could offer.
Sure.
Maybe from a travel standpoint or a cost standpoint, that's not feasible for them. But in the US now, and I have to admit, right, it's also not as good. I can't get the high quality things that you have access to or that CPI has access to. But instead, if we don't just throw the baby out with the bathwater, we'd say, well, what's an option that's kind of lesser on the scale than that? And it's to basically harvest a teaspoon or so of fat, grow your own adipose-derived stem cells. And I believe that these are kind of like, they're not 25-year-old Navy SEALs, they're more like 45-year-old Navy SEAls that they're still good, but they're just not quite as fast, or quite as potent. But my point is that, if a client needs a hip, knee, or shoulder, or some kind of regenerative medicine process, back, spine, whatever, we can work to help them get that treated. And we oftentimes take our clients who are coming in with those types of needs, and if we can funnel them to CPI or that higher level of care because it's best for their outcome, then that's what we want.
Mm-hmm.
And then if they can't make that happen, then we're going to be building a process that I think is going to allow us to help more people when they can't kind of get the bigger or better treatment.
Awesome.
So those are two things that are coming up for us that I'm really excited about. We saw the protest that happened outside of whatever, was it Kellogg or something, like a couple of weeks ago, where there were a group of moms that got together protesting outside the Kellogg's headquarters, talking about the flavor, the colors in the cereal. And I hope we see more of that. I mean, logical discourse with good dialogue to support it.
Yeah.
And the problem that we have is that there are people, stakeholders, who think that they know everything. As we went through COVID, this is all, we've already discussed this, right? People who think they know, thought they had the market cornered, like Mayor, whatever his name was, that says this crazy asinine thing that in a medical sense, we'd have been like, we would have thrown eggs at him, like, get out of here. That makes no sense, But anyway, we need to be, we as consumers need to demand that the people who are giving us advice are actually the people who should be giving us advice.
Right.
We shouldn't, I would not go to somebody who as an employee at Bridgestone and ask them, how do I need to run my business?
Right.
I would rather go to someone who's ran a successful business, buy your dinner, spend a couple hours with you and say, hey, I know I need to grow. I need to change. How can I do that?
Right.
And pick a better mind, somebody who's smarter than me at what's going on,
Yeah, no, absolutely. It is key working with people that are smarter than us in those areas, because that's everything. Our team in Mexico.
You hire the right people, dude. You hire the doctors who got the expertise. You hire the best clinicians on the planet.
Absolutely.
And you give them free reign to do what they need to do.
Yeah, absolutely. Well, I really appreciate, you being in Nashville, you being a friend, and, you help a lot of people with your work. It's important work.
Yeah.
Makes a difference. And if anybody is in Nashville, go see Dr. Howard. Like I said, when I'm in town and I need some ozone IV, I go over there. I don't really have many issues, so I don't come to you for issues.
Yeah.
I have my hospital.
Yeah, it's not like you got chronic health care. You need just some maintenance to tune up on the
exactly.
Tweak the motor a little bit here.
But if I needed a full primary care, I would go to you for sure in Nashville. There's nobody else. So yeah,
we're real thankful to be able to do. I know for me, I tell people the smartest decision I made was marrying my wife. The second smartest decision I made was to leave surgery and jump out of that game and leave it totally. And I don't go to work or go to my office anytime and feel like I'm burdened. I get to do what I really enjoy doing, and I'm really excited about it. And from the standpoint of being able to continue to do this type of work, I'm really excited about it, especially as I see people's excitement kind of coming up, you know what I mean? And knowing what is out there. Cause I'm going to get old soon or older, and I'm going to have to step away from the table, and eventually it's going to be time to pass these reins off to somebody else. And I'm excited to see these younger crowds that are more interested in this approach to staying well, rather than kind of just taking the old approach that our parents did and watching us get sick, fat, old, and dead. It's not what I want. And, we help all age groups, right? Like I see young kids who are struggling. Say young kids, like young athletes, that some of them that are transitioning over to college. Sometimes I see high performing athletes. They're like, this kid's going to go walk on somewhere. I need you to put him in a performance program. We've got athletes, both current and former professional athletes, fighters, some of the fighters that you probably know that we work with, high powered executives. And then regular people who are just realizing like, look, we don't want what our parents had. We got us so much. And honestly, it's not as expensive as what you would think, especially when you consider what you would spend on a dinner.
Mm-hmm.
You know what I mean? Like, I don't know. Hey, can anybody tell me a place where you can go get like a grass-fed steak and take your wife or girlfriend out for a dinner for less than $300?
Yeah.
Probably not going to happen. Our monthly, you would spend less than that per month at our place to basically get a starting level of therapy. So cost-wise, we can do a lot for people, and we're able to plug into their life and really help them move forward. It's just a great thing.
Yeah, and having someone local, not a general practitioner where you're just going to these, where they're a number, but someone where they'll actually know you. I think it makes a big difference, especially, with real health. I mean, you have ozone there. I mean, I don't go back to it, but you have ozone there. You have a lot of different modalities that, that can actually help people. And instead of just giving people an SSRI or those type of things, you're going to give them tools. I guess your office is an office for people who actually want to get healthy.
That's right.
They got to do a little work, but they got to, if they want to get
and
healthy.
They're going to have our support, right?
Yeah.
It's not like we're going to throw them out in the street and say, hey, we don't really have a good structure for you here. No, I will tell you, and we will tell you exactly what to do. Doesn't make it easier for you to go do it, but it does mean that you at least have the steps, and you're going to have support from us. We're not going to not follow up with you. We're going to try to hold you accountable as much as you will allow us to.
Yep.
And I have that discussion with clients. I had a lady the other day. I'm like, you want to do these things, but yet you don't want to change your diet. And I'm like, so what's going to happen is that in 6 months, you're going to continue to do what you want. And we've seen what you doing what you want got you, right? It got you here. Yeah. It got you overweight and fighting all these problems. And so at what point do you want to recognize that your approach is not working and you need to go to my approach? I said, because the problem is that if in 6 months you don't allocate all the resources to what I do, you're going to go around and tell people that my approach and I did not work for you.
Yeah.
And that's not how I like to do things.
Well, yeah. And people, if someone's overweight, people can tell,
That's right. That's right.
Put down the cheesecake.
Yep.
Put down the fried chicken.
Be more intentional.
Yeah, come on. But so I don't think anybody would believe her.
It's maybe not, right?
It's like, you're
this may be the
pounds.
crazy person on the internet that leaves a review. You're like, okay, well, I can tell automatically that's kind of quackery, right?
Exactly.
Maybe it would be that way. But here's what I found too, is that as much as it is to prevent them from going out and saying that we didn't work, it's more about preventing the frustration from me.
Right. Absolutely.
When they come back in, they're like, yeah, because I prepare, brother. When you come back in, I'm going to know what your body comp says. I'm going to know what your labs not only today say, I know what your labs said before.
What do you do for body comp?
In-body analysis.
Oh, nice.
We're actually getting a new one. That's something I should have talked about. We had the in-body 770. We're upgrading to the in-body 970 now. It's going to give us a ton more data.
Well, we have a DEXA.
Okay.
What's the difference between like a DEXA and an in-body?
Well, we can do an indirect measurement of bone density through mineral load.
Okay.
So I can measure kind of like calcium content, but I can't actually measure like bone density like a DEXA can.
Okay.
So it can give you more of like a thickness, a hardness, or however you want to call that scale.
Yeah.
But we're going to measure more of a mineral load or a calcium load, which is roughly correlated to bone density, right? So if their bone density is going down, their calcium load is going to go down. So I will be able to kind of indirectly, detect osteoporosis or osteopenia.
Yeah.
The good news about the 970 is that it gives us a lot more data, but it's also more portable for the patient. So now what happens is all that data gets uploaded to the cloud. You as a client download an app. All of that data goes to your phone. And so you have, you had access to it before because we gave you your records, but now you're actually able to have it on an app where it's and all of the pages from your report will be there.
I see.
So it's going to be much more condensed for the client, and we can have more data to help give them advice on what we're doing. And then I looked at a device today, which is actually a breath test. I don't want to give this away too much, but I can actually start to do with the breath test, I can determine metabolic age. And then we can come back and determine if our interventions improved your metabolic age.
How does it do that?
Well, I just looked at it today. I'm going to come back to you on that. I got
a lot
an
of the
email
telomere stuff, though. So we're like, and I hate to say this, but I'm just going to say this is the truth. The stuff that has to do with telomeres, all of it's bogus.
Yep. I've heard this. I didn't get experience myself, but I've heard other people.
Yeah. So people talk about telomere length. Well, I mean, I've got all the equipment at my hospital to run it, and my scientists are so against it because it's so bogus. If we were to say, well, this is what it is, because you can't get an accurate read. We're actually trying to develop like the first legit
test. Yeah.
Telomere test that there is. I didn't know that, because you hear people say, well, the telomere length shortened, or what? Like, there's nothing. There's nothing that's accurate. We've done them all. It's like you can't get consistency on any of them. And then when you know how to read those papers, you can see kind of what they did. So I was just wondering if it was telomere length, because I was just going to say, hey.
No, I don't think it's telomere length, but I agree with you, right? That probably would not be the metric that I would want to follow. Yeah. I don't know exactly how this test works. I got an email from a marketing, it wasn't a marketing company. It was like a membership club, like some society that I got an email from. A regenerative medicine society, I think. And it was just like, hey, look at this device. And so I went to their website. I spent like 2 minutes looking at it. I was like, okay, this is worth another look, for me to come back.
Yeah, we're going out to Medica in Germany next week.
Okay.
November 7th.
Okay.
And we should, I'll let you know what I find, tell you if there's anything that you might like. But
that's a big, they do like a whole host of devices and diagnostic stuff, right?
You can, it's like, it's big device pharma per se, it's everything you could think of, but we should find some cool. Oh, I meant to ask you, have you ever seen a Weber endo laser?
Not that I can recall.
I would be, they're about 35 grand. I would be willing to buy one for you.
Okay.
You do the training, get used to it. So then I could send one of my doctors to train with you.
Okay.
If you're open to it, but that thing is awesome.
What is it for? Like vein ablations?
Oh my gosh. If you haven't seen this, you're going to freak when you see it. So, it has multiple different fiber optic lasers.
Okay.
That you put in your vein. So it's light in the vein, but you can do for injuries after the stem cells. You can put that in the joint. There are so many. The reason I said I would buy the machine for you is because I know you would do the training, and it's easier than me sending my doctors to Germany to do the training.
To do that. Yeah.
And probably about the same cost. So,
yeah.
But it does so much. All the different lights, and you would learn through their system what all the different lights do inside the blood.
Inside the blood, yeah. Right.
And so there's a lot of old science on it that was from the 1940s, 30s, 50s, because before antibiotics, they used light.
Yeah, always ultraviolet light, right?
So, you run, if I remember correctly, your the blood through a UVA.
We have two. No, actually, I'm sorry, I misspoke. We used to have two. We had a red and a blue, and then what we did is we ordered a unit called the Hemolumen, and the Hemolumen has 7 or 8. I forget exactly how many wavelengths of light in it, but it's got like yellow and blue and red, and it's got a whole bunch of things. So, and now the blood is actually coursing through this little thing where it's got like this whole panel shooting this light at the blood. And we do that on the ozone 10 pass because we can use it in conjunction with the unit.
Yep.
So we're using that light now, whereas before we got the Hemolumen, we couldn't use light therapy on a 10 pass, but now we can.
I see.
Because the units are compatible, and it was only during the dialysis, but now we're using this huge supercharged light therapy on that. I don't know how it compares to this.
Well, the Weber endo, it's like
the Cadillac version of that.
It's the difference between the apheresis that you're doing and like the 10 pass. You can see that the apheresis is a lot better.
A much more potent treatment.
More potent, I should say. Yeah, they're both good. But I'll send it to you, and if you like it, I'll buy you one.
Let's talk about it.
I'll buy you one. Because I've always wanted to have one of those. With someone who knows how to use it. And you can't find them anywhere in America. So
interesting.
Well, Dr. Howard, thank you so much for coming by. We've been going out for over 2 hours now, and let's do it again sometime in the next year.
Yeah, man, it's great to be here. Thank you, and I wish you guys all the best. I know you're doing really cool things down there at CPI, trying to and TAM and trying to grow this cancer program. You're doing great work, and I couldn't be happier to know you and see what you're doing and watch you guys really start to change healthcare in the world. So
Awesome,
congratulations on what y'all are doing.
Thank you very
as well.
much. Thank you for what you do.